Alright guys, welcome. Another night. Before we get into it, any complications with my Brady or anything like that? It's working on it for you guys now. Okay. Any questions? Have any of you guys done the post quizzes or anything like that?
Not yet.
Not yet? Okay. If you guys have any troubles with those,
I've done
let
a
us know.
couple and I just find the best answer.
Yeah.
Like, there's usually like, sometimes, there's
Yeah.
2 or 3 that are right and you gotta pick the rightest.
Yeah.
I find that a little frustrating.
It is.
Get used to that feeling.
Yeah.
National Registry's
National
questions are
Registry
designed
loves
that way,
that.
so
Are you serious?
I'm dead
Oh, yeah.
serious, yeah.
No, I was talking. I was
You're
talking
gonna
to a
want
couple
to
of
open those
guys.
windows because B left the heat on, did not turn the AC back
Oh.
on. So.
Quality.
Don't know why when it's 90 degrees
Yeah,
outside,
exactly.
but
Not gonna lie, I was really hoping for that AC today.
I believe it cracked because it's actually hotter outside. It is
okay.
inside.
Well, I mean, then leave them closed for right now.
Yeah. It's cooler.
Maybe it'll thunderstorm.
Right? We just
Oh,
need a
no.
low pressure system to drop.
Oh yeah, you're riding biking, right?
Yeah, no thunderstorms. I guess that's both. Screw it. Okay, alright, so no questions from my Brady or anything like that. So tonight we're going to chapter 17. Tonight we're covering communications and documentation. Very exciting. But kind of a crucial part of our work environment. These are kind of key components to what we do and what we use. So tonight we're going to go over how we communicate with the hospital, how we communicate with patients, and then covering ourselves with documentation. Okay. So we'll get right into it. Tonight will actually be a little shorter than the previous nights. It doesn't go, crazy long. This is actually kind of a shorter chapter too. But we are going to spend a little bit of time talking about proper documentation and all that stuff.
Chapter 16 is like 3 pages.
Chapter 16?
Yeah.
Yeah. 17's a little dense, but it's not overly crazy. Once we get into anatomy and physiology, that's when we're going to spend a couple classes on it. So tonight we're doing communication and documentation. Then next class we'll be doing medical terminology. And then from there we'll be getting into anatomy and physiology, vital signs, that kind of stuff. Okie doke. Alrighty. So, topics we're going to cover tonight. Communication systems and radio communication. How we communicate over the radio, what's considered good radio etiquette. How we communicate with patients, how we communicate with the hospital. Providing verbal report to the hospital. Interpersonal communication, so how you communicate with dispatch, how you communicate with police, your other crew members on scene. Pre-hospital care reports, so PCR. This is the documentation we do when we finish a call. This is the report that we complete at the end of the call. Just remember, every call gets some form of PCR. Even if there was no patient contact, you still fill out a PCR. Okay? And then special documentation issues. So, communication systems. So, in EMS, we use radio systems. You have a base station radio. You have mobile radios, which we'll go over tonight. Portable radios, repeaters, cell phones, and telemetry. So, kind of the old school way was using portable radios like this to communicate with dispatch, communicate with the hospital, and communicate with your base station. As technology is advancing, we're actually kind of stepping away from radios, and everything is actually occurring either through cell phone or even through iPads. We don't talk about it much tonight, but a lot of the big metro EMS systems are using a CAD system. Anybody who's ever heard of a CAD system, basically when somebody calls 911, that goes to dispatch. Dispatch can then look at their CAD system and say, all right, how significant is the level of call, and depending on what level of care that person needs, what's my closest paramedic, what's my closest BLS truck, that kind of stuff. And it all just basically happens automatically. You have an iPad, your call comes up, and you can put it in right in your iPad, you're responding, you're on scene. You don't have to do any radio communication through that. So that stuff is starting to get integrated up north here. We're still using the radio systems right now, but down in the metro areas, they basically don't even use radios. But we'll talk about them. So like I said, new technology is developing. Computers, tablets, that kind of stuff. Our PCRs that we do, those are all done through computers now. We have a software system through Image Trend. Siren reporting that we use, so Vermont statewide EMS, we use Siren. Depending where you work in other states, they have other systems that they use. Backup radios, those are carried in some systems. So if you're using a portable or a truck radio, you have a backup radio system like Central Dispatch has. If their comm center communications goes down, they actually have a backup radio system that's ready in the event of a thunderstorm or hurricane or anything like that. Radio systems require preventative maintenance, so take care of your radio and your radio will take care of you. So you don't want to bounce your radio off the ground, you don't want to throw it into the lake, any of that kind of stuff. So preventative maintenance, making sure all the buttons work appropriately. We actually take our radios and we send them to Burlington Communications, and they deal with putting in new frequencies, dealing with the battery, testing the batteries, that kind of stuff to make sure they're operational. So this is just kind of a general picture as to how radio systems work. So this would be a portable radio. So a portable radio connects to a tower. Our base radio, this big tower you guys see right here, that's our base radio tower that then connects to another tower up on top of Fairfield Hill. And from there, it uses a repeater system. That repeater system can then send that signal to other repeater towers and display that signal down to an EMS unit or a portable radio or anything like that. So that's how Central Dispatch can communicate with Richford Rescue. Way out in Richford, using the repeater system to send that signal along all the way to Richford.
Don't the rigs have repeaters in them now too,
The
though?
rigs do have repeaters in them. So our portable radios function on 1 to 3 watts, which is not a lot of power to send a strong signal out. So some trucks have them, some don't, but they actually have a system where the repeater is within the truck, so you can connect your portable right to the truck, and that gives you a stronger powering system to send that radio communication out. So that's just kind of the basic setup of how radios work. Your book talks about it a little bit, using UHF versus VHF systems. Most systems now are VHF. A few still do use UHF, and that basically has to do with the wavelength of the frequency. So in a denser kind of metro area, VHF functions a little better than UHF. UHF is able to carry longer distances, especially through cloud work and that kind of stuff.
We use a lot of those in the Midwest.
What's that?
In the Midwest.
Yep. Yep. When you got to send long distance radio communication, UHF is more popular.
Getting barren and planes and that.
Yeah.
UHF tends to work better line of sight.
Yep.
VHF tends to penetrate objects better.
Right. Exactly.
Atmospheric bounce.
Yeah. And that's why sometimes on a cloudy day, our radio communication is poorer than normal. The weather actually affects our radio communication a little bit, and even certain spots we don't have great communication, way out kind of in the rural sections. So, our radio communication is regulated by the FCC. They monitor our radio systems, so they implement our frequencies. They monitor to make sure emergency radio traffic remains open and that other sources aren't interfering with emergency radio traffic. They also they prohibit any profanity or offensive language used over the radio communication, because basically anybody with a scanner can hear our radio communication, right? So HIPAA gets involved with that, making sure you're not giving identifying patient information. No profanities allowed over the radio. That's kind of all given stuff. Because remember, anybody with a scanner can hear you. So, when it comes to radio communication, these are the principles that you are abided by to follow. I'll go through each one of these, how the radio system works, and then kind of the rules that we follow through it. So, principles when using an EMS radio system. Number 1, make sure that your radio is on. It's kind of a given. It's not going to work if it's not on. and the volume is adjusted properly. So make sure you can hear any communication coming through the radio. You don't want it blaring so loud that it's going to deafen you, but you want to be able to hear it clearly. Reduce background noise by closing the vehicle window when possible. What's one of the most common things that people forget to do when they are driving the ambulance. They've got the siren blaring, your window's down, that siren noise is going through the radio, and nobody can understand what you're saying. So roll your windows up, make sure there's not a lot of background noise, so that way Central can hear you clearly, the hospital can hear you clearly, and then communication with your other ambulances, making sure they can hear you clearly. You hear it a lot with PD. There's a lot of background noise if they're running or if there's a lot of wind in the background. You can hear them in Central saying, I can't understand what you're saying. Can you repeat that? So make sure you reduce the background noise when you're talking. Listen to the frequency and ensure that it's clear before beginning a transmission. So if you're hearing kind of a scratchy sound coming from Central, they're hearing the same thing coming from you. All right? So making sure you're kind of in a good area that's got good radio coverage. Obviously, some scenes we go to, it's just not applicable. That's where using the repeater comes into play within your ambulance. Every radio has a PTT button, so a push to talk button. Make sure when you push that button, you allow at least 1 second. That way the transmission goes through clearly, and then speak with the microphone away from you at least 2 inches. So don't put it right up to your face, because then you're just going to come up really scrouchy and they're not going to hear what you're saying. So make sure you wait the 1 second before you speak, and then that prevents you from getting cut off, that first portion from what you're trying to say. Speak with your lips about 2 to 3 inches off of the microphone. When calling another unit or the base station, use their unit number or name followed by yours. So you're saying, hey you, it's me. Okay? So when I'm hailing to Central, I'm saying, Central Dispatch, AMCare 36. Central Dispatch will come back and say, AMCare 36, go ahead, this is Central. Okay? So, hey you, it's me. Alright? So, dispatcher, this is ambulance 2. If the unit are you calling tells you to stand by, wait until they tell you they're ready to take your transmission. So if I'm trying to talk to Central and Central's communicating with 10 different fire departments or something, don't just go ahead and start with your transmission, because they're not going to be listening to you. They're listening to all the other radio traffic. So if they tell you stand by, then stand by. Obviously, if it's an emergency, like, hey, I've got a combative patient, I need PD here now. Each dispatch center kind of has their code red alerts. So for us, if we hail code red, that means I need PD here now. Okay? Or just say, Central, I need PD here, combative patient, whatever works to get you what you need immediately. But if it's not emergent like that and they say stand by, give them that time. Okay? And that's the same thing with the hospital. The hospital's got one person running the radio, and if they've got 3 ambulances out trying to give report at the same time, they're going to get confused as to who's giving report. Ambulances are going to be talking over each other, and that just creates kind of a mess for them. All right? And usually with the hospital now, Northwest we're still giving radio reports, but UVM, all the reports are actually going through cell phone. Okay? And the reason for that, we're able to give patient information through cell phone because that's a direct line to them. It's a closed line, so we're not saying that to the general public. And they really like that, especially if we're coming in with a really sick patient. They want to know name, date of birth, any demographics right off the bat, so they're ready as soon as you get there. They know who's there, and they can go right to treating the patient. Speak slowly and clearly. This especially goes for the hospital. Don't just ramble off everything in 30 seconds or 2 seconds, because at the same time you're talking, they're writing everything you're saying down. So give them a chance. Don't do really long reports with that as well, because remember, you're tying up radio traffic. So if I'm giving the hospital a 3-minute report over the radio, anybody else who's trying to hail to the hospital has to wait for you to be done. And that is the most frustrating thing. So give the vital information that they need to know, keep it limited, and we're going to go over the kind of information that the hospital needs when you're giving them report. Don't give it so quick, but don't take so long either. All right, so there's kind of a fine balance with that. And then use plain English, so the code system. The code system is still used by PD. Some fire services still do use the code system. Our area, we no longer use code system, okay? Plain English. We're not using codes 10.4, 10.8, 1099, that kind of stuff. Plain English, so that way, because not everybody knows the code system. And if you're talking to another ambulance using the code system, they may not know what you're saying. Okay? So plain English, no code system for us. Okay? Any questions with that? Okay. Continuing on, do not use phrases such as be advised. These are implied and serve no purpose to them. So using phrases or words that really don't serve a purpose to your report or what you're trying to communicate with them with. Be concise. Just be clear with them. Right to the point, basically. Courtesy is assumed. Okay, so you don't need to say please or thank you or you're welcome over the radio. You're just tying up radio traffic. Okay, courtesy is automatically assumed over the radio system. Okay. When transmitting a number that might be unclear, so an example saying 15 may sound like 16 or 50. So when I say 15, I say 15-1-5. Where that would come in, if you're giving a blood pressure, if you're giving a heart rate, date of birth, or whatever. Okay, be clear with them because you can confuse what information you're giving, and that can make a difference when it comes to the hospital. So if I'm saying a number, 15, that's 1-5. Okay. So give the number and then repeat the individual digits. Anything said over the radio can be heard by the public, so anybody can go buy a scanner. So everything you say over the radio, everybody in the public will hear. That can be kind of intimidating when you're giving a radio report because everybody's listening to you. Just ignore that. Be concise with your report. Don't give any patient information over the radio. Just a general overview. So anything said on the radio can be heard by the public. Do not use patient's name over the radio. For the same reason, do not use profanities or statements that tend to slander any person. Use objective, impartial statements. So we're not going to make fun of a patient ever, obviously, but you're not going to do that, especially over the radio. Okay? One example I will give you. So whenever we say somebody has alcohol in their system, sometimes patients can get ramped up and aggressive if we say, hey, this patient's drunk or has alcohol on board. The phrase we use for that is ETOH on board. Okay, has anybody heard that? ETOH on board? ETOH on board means alcohol or some form of substance, drug substance on board. Okay, and that's just to kind of cover you because you're standing there giving a report with the patient right next to you. So the patient's hearing everything you're saying. Use we instead of I. What's that? Use we instead of I. As an EMT, you will rarely be acting alone. So it's not I am doing this, we are doing this. Or use your unit number. AmCare 36 EMS will be transporting the patient at this time. Okay, not I'm transporting the patient at this time. Make sense? Affirmative and negative are preferred over yes and no. So affirmative obviously means yes. Negative means no. Because that latter, yes and no can sometimes be difficult to hear because they're so short. Especially if you cut yourself off, you don't allow that 1 second. They may not know whether you said yes or no. So affirmative or negative. Give assessment information about your patient. Avoid offering a field diagnosis for the patient's problem. So we are not officially diagnosing somebody with something. We will form our general impression and we'll develop a working diagnosis. But we, as clinicians, cannot officially diagnose somebody with something, right? I can't go to somebody with abdominal pain and say, oh yeah, it's appendicitis. I'm coming in with this patient, 56-year-old male who's got appendicitis. I can't make that diagnosis in the field. That requires imaging, that requires lab work, right? How I'm displaying that to the hospital is I'm coming in with a 56-year-old male who's experiencing 9 out of 10 right lower quadrant abdominal pain.
Arm injury, leg injury, head injury.
Exactly. Yeah. And if you have to be specific about the type of injury, like I'm coming in with a patient who's got an amputation of the right lower leg, right? You can make that determination. But yeah, things like trying to diagnose somebody with some sort of medical condition that you obviously can't do in the field without imaging or lab work. We're not doing that.
For the ETOH, how
Yep.
if there was plural, if you had two of them on board, how would you say that? ETOH times two?
Times two.
You could do ETOH times 2.
Okay.
The other thing you could say is possible polypharmacy. Polypharmacy. So if they're taking multiple drugs,
Okay.
polypharmacy on board is the other thing. Some people at the hospital may be like, what are you saying? ETOH times 2 is fine. But if you're being specific, like they've got multiple drugs in their system on board, then you can say polypharmacy. Avoid slang or abbreviations that are not authorized. So District 1, we have authorized abbreviations. That comes more with our PCR reports. We're not really going to use abbreviations other than ETOH realistically in the field. Some abbreviations you can use like medications. A good example is aspirin. The abbreviation for aspirin is ASA. Some crews over the radio will say ASA times 324 milligrams. Be clear, say aspirin, 324 milligrams has been administered. Okay. Use of EMS frequencies for only authorized EMS communication, right? So our frequencies are delegated to us as an emergency frequency. We're not carrying conversations over the radio, okay? This is an emergency frequency. We're using this to communicate for emergent situations, okay? So we're only using our radios to display if we're responding, we're on scene, request for additional resources, and then providing patient report. That's the only reason we're using our radios. So no regular conversations over the radio. That's kind of given. Any questions with that stuff? You know, it's a lot of info kind of thrown at you. These are the kind of things that NR EMT likes to nitpick a little bit. You may see 1 or 2 questions on your NR EMT exam asking what is considered, I don't know, do you use affirmative or negative over the radio, or do you use yes or no over the radio, or do you say positive or negative over the radio? Kind of those weird questions that they like to ask. You won't see a lot of questions on your exam about this, but they do like to pull 1 or 2, just because that's how they are. So radio transmission throughout the call. So your initial call often comes through a telephone. Patient uses their telephone or life alert button, call 911. That call then goes to the next available dispatch center. So we kind of talked about this at the beginning of class. When I call 911, that doesn't mean I'm going to get St. Albans dispatch. If St. Albans dispatch is tied up taking a 911 call, I'm going to go to the next available 911 dispatch center. And then that dispatch center will take my information, and once central dispatch is available, they will relay that to central dispatch. Okay? So every 911 call gets answered. It just doesn't mean you're going to get answered by your local dispatch center. Some emergency calls are radioed. Those can come from other agencies, so like PD's out with a subject who's experiencing chest pain. They'll radio into central, hey, can you get Amcare out here? Individuals experiencing chest pain. And then they will hail to us, and we will respond. Without prompt and efficient dispatch and receipt of information, ambulances can be sent to the wrong location. Anybody who's ever been on a fire call or ambulance call ever been sent to the wrong location?
Oh, yeah.
Plenty of times. It happens. Central does try to, if it comes from a landline, they're able to ping right off the bat where that call is coming from. And even the individual's information will come up for them. When it comes to cell phones, not so much. They try to ping, it requires 3 towers to ping that specific location. But if they're in an area that doesn't have much cell coverage, it can be difficult for them to really figure out where that individual is. And even patients who are intoxicated, I've had it multiple times where the patient tells us their old address, where they used to live. We show up, they're not there, and then it turns out they moved to another address, and that's where they were. So if that ever happens, just make sure you document it. You put it in as a delay due to sent to the wrong address. There are some new addresses, especially fire. I know I was with Russ on one call, and there was a new address put in. There's new places being built in the town and the city, and those haven't quite caught up to 911 yet. So the address didn't even exist in our 911 system. So we had to communicate with the patient to figure out, okay, in general, where are you, so we can get the correct address. And that worked out for us. So that can happen.
Do they give you a better, like a map or anything like that?
So we do have on our mobile device tablets, we have the E911 mapping system.
Yeah.
It's not exactly like you think it is. It doesn't come up, here's the patient's address and here's your directions to get there. They give us the address, we have to type it into that computer system, and then it pops up, and then we have to figure out what's our best way to get there.
Okay.
So with the CAD system, that's different. The CAD system automatically comes up where the address is and how to get there, because that uses a GPS mapping system. But for us, we have, and I'll grab them when we go on break, we have actual books of every town that we cover. It's got a blown up view of every individual house, the local streets around that house, and just a general view of the entire town, so we can get an idea as to how to get there, if our technology ever failed.
The VTE 911 is also viewable.
Yep.
So.
And that's what we use, the E911 system. I'll show you guys that when we go on break. I'll grab that so you can see it. It's a love-hate system. It's kind of an old system. You got to take a few minutes to work with it and figure it out. It's a pain, but it is up to date and it works. So, dispatch records all times according to a 24-hour clock. When you do a PCR, you use the 24-hour clock system. So there's no such thing as 3 o'clock in the afternoon. It's 1500. Okay. Some people it takes a little while to get used to, especially when you get towards that midnight hour. At midnight, it's 0005, right? So we work our system off of a 24-hour clock, so military time. They record the time of the original call, the time the ambulance was dispatched, the time the ambulance was reached to the staging area or to the address, and the time the ambulance arrived at the scene. Okay? We also record the time we left the scene, the time we got to the hospital, and the time we were available from the hospital. So dispatch records all of that stuff. Some services record it themselves, but as a backup, you can call dispatch and say, hey, can I get time? I do it all the time. Can I get times for this call? So that way I'm accurate with what Central has. Dispatcher gives the times after most transmissions. So when it comes to your PCRs, especially if you ever got called into court, they're going to look at Central Dispatch's times, and they're going to look at what you have logged for times. If your times aren't matching up, like they're 10 minutes apart, they will pick you apart on that. Okay? So really make sure your times are accurate and matching up with what Central Dispatch has. Okay? Any questions on that? So, many transmissions are between the mobile radio within the ambulance and the dispatcher at a base station. So most of our transmissions, we're talking to Central through our radio in the ambulance. Time to time I'll use my portable radio, especially if I'm on scene and I'm telling them, hey, I need fire here, or hey, I need PD here. I'm not going to run back to the truck and hail to them. I'm going to use my portable radio to talk to them. The other option is you can call them on your cell phone. Either way works. If you guys don't have Central Dispatch's number in your cell phone, get it. Highly recommend it. They're easy to work with. They answer the phone just like a regular individual, and they get you what you need. So whatever service you work for, if it's in District 1, wherever, get your local dispatcher's number, so that way you can pop up and talk to them right away. In some EMS systems, simple standard communications are transmitted by pushing a button on a mobile data terminal mounted in the ambulance. So basically your mobile radio inside the ambulance, it's just the push to talk to them. Some systems, if they don't use a radio system, like the CAD system, if you have an iPad or a tablet or whatever, all your times can be recorded just by pushing a button on that, and that will populate right to dispatch. We don't have that up here. That's something that's down in Metro, busier systems. So for us, we talk to Central through our radios. Carry a portable radio whenever you leave a unit. Why is that important?
In case you need to call for backup.
Safety, backup, any resources you need. If you're on the 4th floor of an apartment and you don't have your radio with you and you don't have cell service, you gotta run back to the truck and you're ditching your partner to do that, right? Never do I ditch my partner, especially if we're in an area or we're dealing with a patient who's aggressive or something like that. I'm never gonna leave my partner alone. And if my partner leaves me alone, he's gonna hear about it afterwards. So always carry a portable radio with you. As soon as we get on shift, that's the very first thing we do. Grab a portable radio. Some people use a radio strap. Those are pretty common now. I use a radio strap. Radios are able to be clipped onto your belt if needed. They're kind of bulky. But as soon as you get on shift, that's the first thing you should do. Grab your portable radio, grab your truck keys.
Is that each EMTs carrying a radio or?
Each one. Depending on the service and available radios that you have. For us, every person on shift has a portable radio, and that's a requirement. They have to have a portable radio on them. So always make sure you're carrying your portable radio on you. So before I get into this, I'll show you guys our portable radio real quick. It's pretty straightforward. Some radios have a screen on it that will show you what frequency you're on, what channel you're on, and that kind of stuff. So for our portable radios, we have a microphone extension. Some don't have this extension, and you actually have to talk directly into the radio. This one you can do either. So for these ones, are on-off. We know it's on once we hear the click, and sometimes you'll hear us checking ourselves. As soon as we leave the ambulance, did I turn it on? Okay, it's on. So I know I'm communicating. So these are automatically on scan. So any radio traffic that comes through, the only thing that we don't hear on our portables is PD, but anything that comes through central dispatch or the hospital or our base radio, we can hear on these. These have 16 different channels. The channels are just adjusted using this dial. Each channel is set to a different frequency. So for us, channel 1 is central dispatch. That's the same on every single radio that's in this building. Every radio here, channel 1 is central dispatch. Each system might have their different channel setup. It's really service dependent on how you have it set up. Channel 2 for us is the hospital. Northwest and UVM actually share the same frequency. So a lot of times Northwest will be hearing radio traffic from UVM, UVM will be hearing radio traffic from Northwest. They do have it set up somewhat so that they're not interfering with each other, but from time to time it does happen. And then channel 3 we don't use very often, that goes to other hospitals, and channel 4 is our base radio. So those are the most common. When you start getting into MCIs, that's when you go to a VTAC system. So a VTAC system is kind of an isolated frequency because you'll be communicating with command. Command will be communicating with the resources like the treatment resource officer, fire officer, medical officer, all that kind of stuff. So we'll get into MCIs later on and how that's communicated, how that's treated, that kind of stuff. But just to give you an idea, that's how our radio systems work. And then when we talk, we have a button on the side. Every time I hear that, it's that 1 second delay. That 1 second delay, you have to wait until that goes off before you can start communicating. So if I start talking while that's beeping, nothing of what I'm saying is going through. Okay? So make sure you allow that 1 second delay. They do have an option like PD uses where you can clip an earpiece to it. You can clip it to your microphone or you can clip it to your radio. I wouldn't want to wear an earpiece all day. That would drive you nuts. But it is an option with some services that you have an earpiece you can wear.
So if you've got multiple ambulances out, you're hearing all the radio traffic for all of them.
Yep. Yep. And I want that because I want to know what's going on with that ambulance, like if they're hailing for help or if they're going to be delayed on scene. I want to know where they are or where they're headed, so that way we can communicate with each other. And that's something you got to get used to when you start working for a service, is really communicating with your other ambulances, knowing where they are, where they're going, and if they're going to need your help at all. Always keep your ears open.
How bad can the communication get when it's busy?
It can get bad.
Sounds like
Especially if all of us, we've had times where 4 calls came out at once, and every single one of our ambulances went out. And then we've got a 5th call that comes through. So then we're trying to figure out, okay, is somebody available? If nobody's available, all right, we need to relay to central, send the next closest mutual aid to that call. So you're trying to run your call at the same time, but you're also trying to figure out what's going on with the other ambulances. So it's a lot of kind of double tasking going on. And it can get chaotic at times, especially if you've got a really sick patient.
Long wait, and there's a long dissertation, more than 30 seconds, and you're waiting to
Yep.
get your in line. And jumping over people, that's a problem too, stomping on somebody.
Yep, absolutely. Especially some services, if we're giving report, that doesn't mean that those other services can necessarily hear us or know that we're giving report. So sometimes we're trying to hail to the hospital, hey, Northwest, this is MK 31, ready for report. And I go 20 seconds without hearing a word from them. I may not be hearing a word from them because another ambulance is giving them a report and I'm just not hearing it. That can happen. So a lot of times, if I'm trying to get a hold of them and I can't get a hold of them through my radio, then I'm going to try calling them if I have cell service. It doesn't happen very often.
Okay.
Franklin County is a little busy, but it's not that busy. But it can happen. So just be patient.
Well, you got the 2 hospitals too, and I'm just like, wow, you're going to be picking up all of it, what's going on in Burlington and here in Northwest.
Yeah, down towards this end and especially Georgia.
Yeah.
That's where we really pick up UVM's radio traffic. But other than that, like when we're up north, we don't hear it that often. Because their repeaters are set to transmit down there, not necessarily up here.
So your radio doesn't have a screen on it, so you could just have to memorize all 16 channels?
Yeah, I mean, it's numbered up on top so I know what channel I'm on.
Well, yeah, but
But if I turn all the way to one direction, then I know, okay, I'm on channel 1. And then
yeah, I mean, it's
2,
easy to
3.
remember the, you know,
The clips.
top 3 or 4 that you use.
Yeah. Yeah, because I mean,
Can't imagine that
realistically...
you know what channel 11 is off the top of your head, you know?
Right. And we really memorize just those 4 main channels because those are the ones we really only use.
Yeah.
The other ones, like VTAC 1 through 11, I don't have those memorized. That's where you got to work with your, if you're in an MCI, you got to work with your control officer to say, okay, what channel are we going to be communicating on? And what channel do you want me set to?
You got the man down system on that?
Yes. So with dispatch, so do you mean just pushing a button?
That's a distress button, but then you got the man down system, and if you're down, you can't press the button.
Okay, so, yeah. So the only way we're really communicating with that right now is using code red.
Right.
So hailing over the system, hey, code red, I need PD here, or whatever. But if I go down and I'm not able to communicate on my radio, I'm not able to communicate on
You've
my
got
radio.
the one system you can put on those things, if you like, something happens, and you're down, you go prone. After a few moments, it will start signaling that you're not moving.
Yeah.
You know,
Though,
it's
yeah, those
trigger
systems
on.
are available. We don't have those. Someday maybe. Busier services do have those. For us, I don't really know of any services around here that have those. And that's why it's kind of important that you and your partner carry a radio. So if I go down, my partner can at least hail the central, hey, I need another ambulance here and I need PD here, because my partner just went down.
Both go down.
Shit luck. Yeah, you're right, it can happen, absolutely.
Oh, yeah.
Definitely, especially in fire, when fire goes to inside a burning building, using the buddy system, and I forget the names of those when the alarm starts going off. 'Cause you have to move
Pass
them along.
device.
Yeah, pass device. So those can get really loud. We don't have anything like that for us. That's why they do have those. So that is a good point. So, radio medical reports. So when we're giving report to the hospital, report must be given to destination hospital so I can prepare for your arrival. So That's something that sometimes gets forgotten, especially with new providers, is giving report to the hospital. You know, you're taking care of the patient, you really get focused on doing your assessment, doing your treatments. Well, a key part of that is giving report to the hospital, letting them know that you're coming, letting them know what you have. And a lot of times, not a lot of times, it's not very often, but it does happen. We arrive at the hospital and we're like, hey, we're here, this guy's dying. Where is everybody? And they're looking at you like, well, you didn't talk to us or tell us anything. You will catch flack for that. Making sure you give that report. Even if you're just doing an interfacility transport, you still have to give a report to the receiving hospital. Okay? So anytime we're transporting somebody to a hospital, you have to give them some kind of report. Let them know what's going on. Reports may be by radio, verbally in person, in writing, or in all three ways. So we always give a heads up radio report or cell phone report before we arrive. Then when we're at the hospital, we give a verbal report, so a verbal handoff as to what we found, what we did, what's going on with the patient, and then we fill out a written document afterwards. So radio report is specifically structured to present only most important information. So what would be an example of something that's really vital information to get to the hospital before you arrive?
Any medication you give them?
Chief complaint, medications we gave, absolutely.
Vital signs.
Vital signs, yep.
ETA.
ETA,
Any
Yep.
major injuries?
major injuries, exactly. That's all stuff that they need to know. I'm not going to go into, well, they had a UTI 30 years ago and got put on this antibiotic. If it's not relevant to what you're dealing with, they don't need to know that over the radio. You can pass that off when you get to the hospital and let them know about that. But when you're giving a radio report, a heads up, tell them the immediate things that you're seeing, the immediate life-threatening things that you're identifying, and the treatments you did for that. Keep it simple, keep it structured. So basically, in your words, of the patient, you're painting a picture for the hospital. And what they mean by that, Northwest, this is Amkita 31, we're transporting it to you at this time. 36-year-old female, chief complaint, abdominal pain, ongoing since yesterday. Patient's vomited, ×4, noted to be hematoemesis. Anybody in here know what hematoemesis is? If you don't, you're gonna learn. Bloody emesis. Just giving that vital information to them. That's what they need to know. What you found, what you did, and any major identifying things that they need to know right off the bat so they're ready for you. That's kind of the most important thing. So communication from the ambulance can be by radio or cell phone. Cell phone is perfectly fine. Unfortunately, Franklin County, there's a bunch of areas that we don't have cell coverage. It happens, even in the city. I've found areas where I don't have cell coverage. So if you don't have cell service, give it over the radio. It's really your personal preference. You can get the hospital's phone number, so you can talk right to their unit secretary to take report. I suggest getting that. Yeah, exit 18 to exit 17. Worst spot, every time.
Do you guys have a cell booster in the truck?
Yes, now we do. Prior to being bought out by Butler, we didn't. Now since Butler's bought us out, we have a hotspot in the truck with a cell phone
I don't
booster.
mean a hotspot, like a cell booster.
Yeah.
Okay.
Yeah,
Like
it's helped a little bit.
I have a cell booster in my car. I could drive from Enosburg to Burlington
Yeah.
and keep
You
a...
still drop in Sheldon?
There.
Sheldon dip.
Can't tell the background.
Yep.
Well, I tell you what, you just
Everybody
Can't have you overstating the
Man, that
usefulness.
freaking truck was hurting over.
It doesn't drop the call for like 5 seconds in the dip. You can't talk.
Yeah, the dip, yeah.
You don't lose the call.
Yeah.
The
But
rest of the way you can...
depending how long you lose that call, sometimes the hospital's like, hello, are you there? And you
Yeah.
just hang up, because they're not going to wait for you.
Once you fill those spots, it's like it's just drop. Don't even try.
It happens.
All back.
And kind of know those areas would be my suggestion. Know your cell coverage areas. If you know you're transporting and you're coming up to a spot that you're going to lose cell service, either give your report ahead of time or you're going to have to wait if you want to use a cell phone until you're clear. So that's why if you're coming up to those spots, know where you are, so that way you know if you need to give a radio report. Okay, whatever works for you guys realistically. if you prefer one over the other. So medical radio reports. This is the stuff, the information that we're going to provide to the hospital. So, unit identification. You don't necessarily have to give the level up to the provider. This hospital doesn't really care about that. Even UVM doesn't really care about that. Now, if you're doing an intercept, like an AEMT intercept or paramedic intercept, then they're going to want to know, hey, we're doing a paramedic intercept with MDR or Richford Rescue or anybody. They're going to want to know that because then they know, okay, they're handling for a paramedic intercept, so we know this unit's out to a sick patient and we'll prepare for them. So definitely give your unit identification. They need to know that. As to the level of that unit, you don't necessarily have to give that. Estimated time of arrival. So that's the information we're giving when we're transporting to the hospital. Usually I kind of lead with that. I'll say this is AmCare 36. We have approximately 5-minute ETA to your facility, transporting at this time a 36-year-old female. So really, they need to know that right off the bat so they know how quickly they need to start setting up for you guys. Especially this hospital. Unfortunately, they have limited resources there, so at nights they've only got 2 nurses and a doc. That's it. So give them as much heads up as you can, especially if you're coming in with a cardiac arrest or a priority 1 trauma. The more heads up you can give them, that allows them more time to get set up for you.
Because we're not very far away, so.
Exactly.
You know,
Do you have any acronyms for radio transmissions? Like sailor, sex, age, incident?
No.
No, nothing like
No,
that.
just straightforward with it.
Okay,
Don't worry about the
Try to
acronyms.
Concentrate on that then, okay.
Yeah. The only acronym we realistically use is ETOH on board. That's the only one, because they know what that means each time. But acronyms for age, sex, that kind of stuff.
I mean, just for me to memorize, so I guess I just have to memorize.
Oh, I got you, an acronym to remember all this.
Yeah.
I don't have a specific acronym
Okay.
for it. The way I learned this was just basically doing it, experience. I worked at the hospital for 4 years, so I got to hear, I took report from every ambulance service, and I kind of developed my system for what the hospital's looking for. I'll see if I can get a copy of their run sheet for you guys to see, so you can see exactly what information they're writing down when you give them report. Let me make a note of that actually. Because you'll see then what information, they have a little chart system that they use, and what information that they write down. UVM uses a very similar one. You might need to steal one of your pens. Don't forget. Thank you. Okay, thank you. So next class, I'll show that to you guys just so you can see what they're looking for. Okay, so unit identification, estimated time to arrival, patient's age and gender, chief complaint, and brief pertinent history of present illness or injury. If their major past illness has kind of any relevance to their current chief complaint, then you want to give them that. I just use past illness kind of loosely because when we start going to elderly individuals, they will have a medical history list that takes up 10 pages. And you're not going to give all that information over the radio. So just give the relevant stuff. Okay? If I'm going to somebody with chest pain and they just got out of the hospital getting stents 2 weeks ago, that's important to know, right? There's a good chance they're having another heart attack. So give them the relevant past medical history. Mental status. That's probably a good one. Telling the hospital, are they responsive? Responsive to pain, responsive to verbal stimulation, A&O times 4, that kind of information is good for them to know. What is their baseline? Do they have a prior history of dementia? If they show up and the patient doesn't know their name or where they're from or anything like that, knowing is that normal for them? Or do they have a history of dementia and that is their baseline normal? So kind of displaying that relevant information is helpful to them. A set of vital signs. Unless you're under a circumstance where you can't get a set of vitals on a patient, doesn't happen very often, but from time to time it does. When we're dealing with combative patients or patients who are willing to go to the hospital with us, but they don't want us to touch them, we respect their wishes. If we can't get a set of vitals on that patient, then just relay that to the hospital. Unable to obtain a set of vitals at this time. Okay? Just display to them, is the patient awake? If they're awake and talking to you, their vitals are probably okay. Right? If they're unresponsive, then you should be able to get a set of vitals. Pertinent findings of physical exam, so any obvious major injuries that you see that they'll want to know about. Emergency care given, so any treatments that you guys rendered, they'll want to know that, definitely. Response to emergency medical care. So did they get better or did they get worse? And then contact medical direction if required or if you have a question. So what is medical direction?
Doctor,
Doctor. What doctor?
your the physician at the hospital who's on
duty.
emergency.
Emergency physician who's working on duty at that time, right? So we have a medical director who oversees all EMS, guides us on our protocols, QAs us on our calls, and just is our general physician to oversee our EMS licenses. And then we have a medical direction who is the on-call physician at that time. That's who you're going to talk to. So if at any point you need to talk to medical direction, just let the hospital know, hey, this is AmCare 36, Paramedic Wolski. I would like to speak to medical direction. Then they'll put me through. I will say with that, if you're getting orders to do something, it has to be from a physician, okay? Sometimes,
Not the charge nurse.
not the charge nurse, not any nurse or LNA or ED tech or anything like that. Those orders have to come direct from a physician, and that physician needs to talk directly to you, because that's where you can get into trouble. Okay?
Will there always be a physician on duty? And if there wasn't, will the charge nurse substitute for his authority?
It happens from time to time, especially if that physician's really busy. However, what I will say with that, if you're requesting any form of treatment, that order has to come from the physician. Point blank, period. Joe will agree with me on this. It cannot come from a nurse if you're doing any form of treatment. Okay? And it does happen. The physician's busy, the charge nurse is answering the phone saying, yeah, go ahead with your, 0.3 milligrams of epinephrine. I can't take that order. I need that order to come from a doctor, because you can get tied up in a lawsuit if you took that order from a nurse and it was detrimental to the patient. So just remember that your order has to come from a physician.
Possibly also PAs and NPs can also get it.
Yes.
I'm not sure about this state. Every state's slightly different, but I know in like Maine, PAs and NPs are medical direction also.
Yep. Some
But
hospital systems only have PAs and NPs.
Yeah. I'm just because we're doing a bunch of crew swapping and things right now, I'm gonna
Yeah.
close the door just
Yeah,
to
yeah.
keep things
That's
quiet
fine.
for you guys.
Thank you. So yeah, I did forget to mention that. Here, there's always a physician in the ER there, so our orders come from a physician. Some hospitals like Gifford or what's the one down in St. Johnsbury? I can't remember the name of that. Northeastern Medical Center or something like that.
Something like that, but I can't. Right up
So,
the hill on the four corners.
yes,
Yeah, I can't remember the name of it. Always looks like it's a parking garage.
yep.
Yeah.
It's very tiny.
Yeah.
Much tinier than our hospital here. So that hospital, they don't always have a physician on. A lot of times there's only a PA on or an NP on. And that's okay to get orders from them. But the biggest thing is your orders have to come from a practitioner. Okay. Answer this question.
Poison control, they know all the different poisons. If I talk to the medical direction, I wouldn't have to call poison control to get an answer about something that some kid took.
You're saying calling the physician about it or calling
Yeah,
poison control?
the physician would know, or he would, every poison there is.
Call poison control. 100% call poison control directly. And poison control is fantastic. I love those guys.
Are they doctors?
They're not doctors. Well, I may screw this up. They sometimes have a doctor who works with them, and they will advise certain treatments. So they are a great source to advise what treatments we should give, depending on the poison. and then we would run that through our medical direction.
Okay.
And say, hey, I've talked to poison control, this individual took this substance, their recommendations are to do this form of treatment. Is that okay with you? And medical direction, 9 times out of 10 will say, yeah, those guys are experts on it. Do what's within your scope.
Okay.
And the fantastic thing about poison control, so poison control has contact with all the hospitals. So before we even arrive at the hospital, they're faxing all the information about that poison to the hospital before we even get there. I love them. A lot of different poisons we deal with, you know, there's thousands of them out there, and we're not going to know the treatment for every single one of them. And they'll tell you what to look out for. They'll ask you, you know, how much should they take? If they took this much, then you should expect this to happen. If they didn't take quite so much, then you don't need to be so concerned about it. But they're a great resource. Everybody have Poison Control's phone number? Easiest phone number in the world to memorize. I'll get it to you afterwards. It's really simple. It's like 2222-12222, something like that. I'll double check that one might be somewhere else, but that's a great resource to have.
Okay.
So we said personal findings of physical exam, emergency care given, response to emergency care. Did they get better? Did they get worse? And then contact medical direction if needed. Communication with medical direction. So give information clearly and accurately. So don't ramble off to them about random things that aren't relevant to your call. They're busy. They're a physician taking care of God knows how many patients in the hospital at that time, right? Tell them the relevant information and be direct with what you're asking for, okay? Are you asking for what things you should be looking out for, or are you asking for a specific treatment? As long as it's within your scope. They're not going to know who you are right off the bat and what your cert level is and what's within your scope, right? They're focused on their things. So if they're giving you an order to do something that's not in your scope, tell them that. Say, hey, this is not within my scope. I will have to call for an EMT or a paramedic to administer this medication. Okay? But just be direct with them. They're nice enough. They'll get to know you. After receiving order or denial for medication or procedure, repeat back word for word. Does that make sense? So Dr. Cutler is telling me to give 6 milligrams of adenosine. I'm going to repeat back to Dr. Cutler, verifying you want me to administer 6 milligrams of adenosine, correct or affirmative. And he will say, yes, please administer 6 milligrams of adenosine. Order confirmed. Okay, that just covers you, so there's no confusion and communication with what you're doing. All right. If order is unclear, ask physician to repeat. Sometimes they'll give you a hard time about it, saying, hey, I'm busy, I don't have time to do this. I don't care, I'm dealing with a patient, take the time. Okay? You're trying to get your orders, and you're trying to be clear with what those orders are. If order seems inappropriate, question the physician. This is one of those times we can question the physician, saying, hey, you know, I know you're an MD, however, I'm concerned that this procedure or this medication will have this effect, and I think it'll be detrimental to the patient. And then they will either agree with you or say, nope, I think it'll be appropriate for the patient, and I want you to administer the treatment. What I will say with that, so if you're uncomfortable with doing a treatment, you're disagreeing with the physician, number one, back your butt up. Because if the patient then crumps because you decided not to do the treatment, you better have it documented really well as to why you decided not to do it. Okay? But if you're doing a treatment that you feel is inappropriate, then don't do it. Right? Anytime we give a medication, can we take that medication back? Absolutely not. As soon as it's given, it's gone. Okay? So they're good to work with. They're never going to put you in a situation that typically you disagree with. I've never had that situation come up in my experience. I just explain to them my reasoning for what I want to do, and they either say yes or no. Okay? It's pretty straightforward with them. Any questions on that? You'll get used to talking to medical control. It's just another individual you're talking to. They all have MD licenses. They're
You
nice
find with
people.
us being so close that they deny those orders a lot of times?
I've noticed that it's physician dependent.
Gotcha.
Every physician kind of has their own
You have to
way
come
of
out of the
working.
city, for example.
Yeah. Yeah. So some treatments that I do, if I'm really close to the hospital, like I'm a minute away, they'll sometimes tell me, hey, why don't you wait on that treatment? You're almost here. I'd like to lay my eyes on the patient before doing so. If that treatment is like life-saving, like it's within my scope, I know what I'm doing, and I'm not required to call med control, I'm going to do it because I want to save that patient's life, right? So some physicians are kind of reserved and they don't want you being aggressive and that kind of stuff. They'd rather lay their eyes on the patient before any interventions are given. It's very physician dependent. Okay. Why don't we take like a quick 5-minute break because then we really get. All right, guys, we're going to get back into reporting. So we've covered radio communications, and now we're going to talk about verbal reports. This one's kind of short. The documentation portion is going to be a little longer. So verbal reports. Verbal reports are what we provide to the hospital when we're doing handoff. So a verbal report is given upon arrival at your destination, whether it's to the hospital or it's to a nursing home. You are required to provide off verbal report of that patient, depending where you drop them off. If you're bringing somebody home, then obviously there's nobody to pass off report to, but that patient needs to be aware of what's going on before we drop them off. So introduce the patient by name. They're a person, treat them like a person, right? When we go to the hospital, we're not going to say, hey, we're here with a 56-year-old male. No, this is John. We're here with John. He's a 56-year-old male, chief complaint of chest pain, right? Treat him like a person. Give complete and detailed reports. So this is our opportunity to get in depth with what we found, what their medical history is, and what we did. All right, so this you can take a little longer to provide a good, thorough report to either a nurse or a physician. So elements of a verbal report. Chief complaint, that's an important one. Why the patient called 911. History that was not given previously, so anything you left out when you were giving a report over the radio or over the cell phone. Assessment, treatments given en route, so what you found and what you did. And then additional vital signs taken en route. So they're going to trend those vital signs, all right? This is where you started at baseline. Did they get better or did they get worse? Because they'll look at that right off the bat and say, okay, this patient's getting sicker. We need to intervene right now. All right?
Can I interject something on the verbal report?
Go for it.
So, I think, well, have you already talked about radio reports? I wasn't here for the first
Yeah.
part. Okay, so like, I kind of treat like radio reports and verbal reports, I feel like it's an art form. Because you are, like, it's important to kind of organize your thoughts. Because, you know, you may be up at Northwestern, just like simple patient with a nurse that you've met a dozen times, and it's kind of just having a conversation. Or you're down and you're giving a report to the trauma team at UVM. They expect you to be a little more like on your game. So if you come in like, yeah, this is Mr. Smith, he's in a motorcycle crash, and you're like all over the place, they're gonna notice that and like they're gonna interrupt you and they're gonna pull the information out of your face. So it's I think it's just, you know, it's kind of one of those things. It takes practice, but just you know, it's important to kind of organize your thoughts and give a good comprehensive report that flows.
Yeah, that's a great point.
I was gonna open the door anyway.
So yeah, really sick patients, especially, they need to intervene right away. Be straight to the point, especially when you're dealing with the stroke team, the trauma team, the cardiac team down at UVM. Like, don't start tangenting off on something completely irrelevant to what you're dealing with, because they're going to look at you and just say, I don't care what this guy has to say now. I'm intervening, you can stop your report and I'll figure it out from here. Okay?
How much would you potentially repeat what you had already radioed in?
Pretty much everything.
Okay.
Yeah, because the so like up here at Northwestern, it's the unit secretary, which is usually like an ED tech that generally takes the report. The nurse you're giving a report to may not have heard your radio report. Same thing, the trauma, like you give report to the comm center down there. So like the doctors and nurses and everybody, they basically get a page that says like AmCare 5 coming in, red trauma, motorcycle crash. That's it.
That's all I know.
That's all they get. So when you come in, you basically have to repeat everything you said.
Yep.
So.
Yep, exactly. That's a good point. So yeah, like Derek said, you'll see the nurses up here all the time. You'll kind of develop your own system with how you're giving them report. The biggest thing is if you do a treatment or you find something, don't forget it. Because they might flack you on that later on saying, hey, why didn't you tell us you gave the patient aspirin? We just gave them more aspirin, right? So try not to forget anything. That's why write everything you do down. Don't try and memorize everything you did on that call. So be concise, give a good detailed history, relevant information about the patient, anything you did or you found. And then additional vital signs. EKGs. Up at Northwest here, we're not really transmitting EKGs. They have a very old system. Basically has to talk to 10 different satellites and then talk to NASA. NASA sends that to them.
Yeah.
It just takes forever.
Sends it via fax
Yeah.
still, so yeah, it's like...
It's kind of crazy. The new Bluetooth systems, especially with the new monitors that are out there now, like the Zoll X series, that uses a Bluetooth system through cell towers to send EKGs directly to the hospital. That's more UVM that takes those, because UVM takes those and actually will give it to a cardiologist, and the cardiologist will look at it if it's a STEMI or anything like that.
Like prior to you getting there, they'll look at it?
Yep.
Wow.
Yep. So that's handy. Each service might use a different system. It's kind of service dependent on what you use. Up here, we don't really have that with Northwest. It's more with UVM. Any questions about verbal report? Legality-wise, you cannot just drop the patient off and run. That is completely against the law. Okay? When we get to the hospital, I am still in charge of that patient, and that patient is still under my care until I've given report to somebody. If I get there, they're slam busy, they don't have a nurse available to take report from me yet, I could be with that patient for a half hour, waiting to give report. That patient is still under my care, even if I'm at their facility, not in my ambulance. Till I give report to somebody else, that patient is still under your care. So it's considered abandonment if you get there, put the patient into bed, and ditch off and run. Okay?
Technically,
Don't remember that.
technically you have to give some sort of written report. Like
Yeah.
we call it a drop form that has basic demographics and stuff like that. It can be as simple as like I pull out my notepad and jot it all down. There you go. That counts. But technically, a transfer of care hasn't occurred until a written handoff has occurred. So.
Yeah, and they have a photocopy machine. Every hospital has an EMS room with a photocopy machine, so you can make a photocopy of your drop form, leave it with the unit secretary or the nurse. And so that way at least I have that. Northwest, actually this month, had a district meeting. We'll talk about sepsis later on, but with every septic patient, they need to know the amount of fluids we gave to that patient, because that's all part of sepsis protocol. We'll talk about that later on, but the point of that is that we have to leave them a drop sheet, especially on those patients. Okay? So always make sure you give some form of SBAR report to either a nurse or a physician. I will say if you give report to a physician, a lot of times that physician may not relay all of your information to the nurse. So if I give report to a physician, I also make sure I give report to the nurse who's going to be caring for that patient.
Verbal and written.
Verbal and written, yep. Yep, exactly. You're written, so we do a whole documentation later on after the call. We're not going to crank that out while we're at the hospital and give it to them. We do that drop sheet, which is basically just our charted out notes that we did during the call, and leave that with them.
Just a down and dirty form.
Yep.
That says name, date of birth, any pertinent information found in treatments given. That's all the drop form really is. It doesn't have to be like the whole how you found them. It's just it's a down and dirty, very quick thing.
Yeah. Any information I wrote down on a piece of paper on my call, I just make a photocopy of it and give it to them, and that counts. So that's a requirement by the state of Vermont that we have to leave those with the hospital. Okay. Any questions about verbal report? Pretty straightforward. Interpersonal communication. So, with communication, EMTs must communicate with others involved in patients' care. So if there's a first response agency, we're working with first response. We're working with fire. We're working with PD. Anybody who's at the scene, talking with bystanders, figuring out what happened. If first response is on scene, what did they find right off the bat? What care did they do? If I just jump in, push them aside, and say, nope, they're under my care now, I don't care what you did, how is that helping the patient out at all? Right? So communicating with people on scene. If you call for an intercept, whether it's a paramedic or an AEMT, providing a report to that whoever's intercepting you, saying, hey, this is so-and-so, 55-year-old male experiencing chest pain. This is what I found. Here's a 12-lead EKG, and these are the treatments that I've done. Okay? You're giving report to whoever's helping you out. All right? I do that with my team. If I have another ambulance help me out and arrive on scene, I'm giving them report as to what I found and what I've done. Also with home health nurses, we take report from home health. Sometimes they're at a patient's house and they call us and say, hey, this patient's not doing well today. They know everything about that patient. They go to that patient's house almost every day. They're a great resource to figure out what's going on. Some of them. I work with them quite a bit. My significant other is a home health nurse, and they're a great resource to figure out everything about that patient. And then also the patient's family, especially if the patient has a history of dementia or they're altered, talking to their family members, communicate with them. Speak candidly and respectfully to everyone, right? We want to be professional. We're not going to start yelling, being chaotic, swearing at people on scene, that kind of stuff, because that's just going to escalate everything and make it worse. So be polite, be respectful, gather information as much as you can about the patient, and complete any necessary and appropriate transfer of care, all right? So be professional. That's kind of the big thing here. Be polite to the patient. You're going to go to patients who are swearing at you and want to hurt you and that kind of stuff. We're still being professional to them, okay? Treat everybody the same. Communication techniques learned by experience may be more difficult with those in crisis. So each person we go to, we may have to use a different communication technique, right? Especially when we go to a family member's house who just passed away. Knowing how to deal with that family member who just lost their loved one, right? Some people want you close to them, they just want to talk to you, you're there to listen. Each person's different, and you really kind of develop that with experience. We're not going to talk to a 2-year-old the same way we're going to talk to a 40-year-old, right? Working with pediatrics parents, still treat the kid with dignity and respect, right? Everyone can improve communication skills by learning effective communication techniques. So this is something you kind of develop as you get out into the field, how to talk to a patient. Your first ever EMS call, we kind of noticed this with new providers as soon as they get out on the truck. You've learned everything you have, you've got your EMT license, now how do I talk to this person, right? We've seen that before. That's where kind of your book smart and your street card smart comes in. You're just talking to another individual. It is a total stranger who we've never met in our life. We're now in their house and we're expected to save their life. Still talk to them like another human being. You gotta have verbal skills, right? If you're uncomfortable talking with strangers, then practice, get used to it, because that's what we do. You need to be able to talk to people, and you need to be respectful to them.
I think I've mentioned it once before in this class. Like when I was started as an EMT is when I was 18 years old. Fresh out of EMT class, I spoke to people like I was robotic. I was like, hello ma'am, my name is Derek. I'm an EMT with X ambulance service. Tell me your name. Like it's like you just gotta turn your swag on, talk to them like another person. Like just a normal human being. It's easier said than done. And as far as the therapeutic communication, we've had calls where it's really a team dynamic. It's like I'm trying to talk to somebody in crisis. It's not really I'm not establishing a rapport. I'm a ugly bald guy. I'm not getting through to them. Joe, he's gonna try something different. If we got a female on the crew, maybe that it's less intimidating for It's just you really gotta kind of just play it. It's a game.
A lot of psychiatric calls we go to.
Yeah.
Some work better with working with crises than others, And a lot of times we go to those and we kind of notice that the patient is more open to one member on the crew than they are to the other. work with what you got. If that patient's more open to the one member, then allow that member to talk to them. Ask the questions and that kind of stuff. And on your side, there's always something to do, whether you're getting a set of vitals, you're talking to a bystander, or a family member to get information, right?
Yeah. We had one the other day. I was working with Grace and Courtney. It was an elderly female with dementia, and she just kept giving me this look like, yeah. So like I stayed out of the room. Like Courtney and Grace, they did their thing, like, and I just stood back because like I was obviously an antagonist in that situation. So like wasn't, I'll go do something else. Like I just left. So.
And that's big, learning to read people, watching body language, that kind of stuff. If they seem very intimidated by you, then obviously don't be aggressive, have a reserved demeanor, right?
Nice.
Appear open. Exactly. Don't go up to somebody like this, appearing mad or pissed off or whatever, because they're not going to open up to you and tell you what's going on. Have an open demeanor to them. Look professional. Okay? Use eye contact. Don't try and talk to somebody looking the other direction. It's pretty straightforward. Show interest, attentiveness, and comfort. So act like you want to be there, right? You're there to take care of that person. Act like you want to be there to help them. Okay? That's what we're here for. Be aware of position and body language. Face patient at eye level with arms down. So a lot of times when we go to somebody, I'm not standing over the top of them trying to talk to them. Get to eye level with them. If they're sitting in a chair, get down and talk to them. Okay? You don't want to be intimidating to them. So just watch their body language, watch your body language, watch your partner's body language. Okay? Kind of read what the patient's giving you and telling you. Communicating with the patient and others who are in crisis requires skill and tactic. Okay? So you can see the EMS provider is down at eye level with the patient. He's engaging both the patient and the patient's family member. Okay? He's not just focusing in talking to the patient because maybe the family member has more information than the patient has. So he's engaging both of them. Being tactful. Sometimes patients don't want you to just come up and grab them or check their pulse or that kind of stuff. Open yourself up. Say, hey, my name's Garrett with AmCare. I'm a paramedic. What's going on today? Okay? Be open to them. Engage whoever's there on scene. Use language the patient can understand. Do not use medical terms and explain what you're doing. Okay? So that can be one of the most intimidating things if I start throwing a bunch of medical jargon at a patient that they're not understanding. They don't like that. I'm not going to tell them, hey, I'm seeing hematoemesis every time you vomit, or I'm not seeing hematochezia in your stool, that kind of stuff. Okay? Be truthful with them. Don't lie to them. Never should you ever tell a patient, you're going to make it through this, you're going to live, I promise you that. Don't ever do that. Don't make false promises. Okay? The professional way to say that is, I'm doing everything I can to help you. Okay? Explain what you're doing. This is something that sometimes we forget. If we're checking a patient's blood glucose or we're doing a 12-lead EKG, that kind of stuff, tell them you're going to do it. Don't just start grabbing their arms, or if they're a trauma or whatever, don't just start cutting clothes and that kind of stuff. If they're awake and talking, tell them what you're doing. Okay? You don't want some stranger coming up to you and just start doing a bunch of procedures on you without understanding what they're doing or why they're doing it. And be honest. Dishonesty ruins confidence and rapport. Okay? Don't lie to your patients. Don't make false promises to them. Okay? Be honest with them. Tell them what you're doing, why you're doing it, that kind of stuff. Use patient's proper name. So some patients have nicknames. Whether it's Billy instead of William or something like that. Some patients, we have some out in the community that don't like their full name. They like their smaller name. So ask them, what do you like to be called? Okay, that's totally appropriate because you want to talk to them the way they want to be talked to. And listen.
avoid terms like dear, sweetheart.
Yeah, that's a big one.
Yeah, it's
I
a
have a
big
problem with
one.
that.
He does that a lot.
I do that a lot.
And
It's bad.
Jameson has followed suit with you,
I know.
by the way.
Yeah.
Yeah.
It comes out of all of us. I mean, we all say it, but just try to avoid things like that, because some people, I've run into it before, they do not, especially in the elderly population, they do not like being called dear and sweetheart and terms like that. So.
Yeah, and that kind of all goes back to like reading people, because like usually I start with, you know, like sir or ma'am, and sometimes they shut me down right there. Like, I ain't a sir, I work for a living. It's like, oh, all right, you know, Mr. So-and-so, no, call me Bill. Okay, Bill, like, you know, so it's just kind of, you know, like, I always start with sir or ma'am, or, you know, and then digress to the Mr. or Mrs. and eventually they knock me down to just calling them by the first name is usually how it works. But
We're trying to start off on the right foot.
yeah, you know, so elderly folks, I seem to get by okay. You know, people my own age, like they just want their first name. Generally, sometimes it's like, oh, sir, yeah, all right, whatever. You know, again, it goes back to the reading people.
Yep, exactly. That's a great point. So we're always a set of ears. The most important tool we have in the entire ambulance is between our ears, okay? Using our ears, using our brain, listening to them. Take all the information in that they're giving you, okay? Sometimes they like to go off on tangents that are completely irrelevant to what you're dealing with. I'm still listening to them, I'm not blowing them off, but I try to keep them on point. So, you know, if Mr. Smith goes off about how he fought in the Vietnam War and stuff, unless it's relevant to his care, you know, I try to keep him on track and say, you know, thank you for your service and fighting in the war. Talk to me about your chest pain today. When did that start? Okay? Be polite about it. Don't just cut them off and say, hey, I don't care that you served in Vietnam. Tell me what's going on today. Okay? Be polite about it and try and keep them on point. Position yourself at or below the patient's eye level to be less intimidating and to aid in communication. So that can sometimes be forgotten. When you're talking to somebody, you don't want to be intimidating to them, especially with kids. Okay? When we talk to kids, typically we'll get down to their level and talk to them that way. You want to appear open, and you want to appear like you're ready to listen and willing to be there. Okay? So always talk to them at eye level or below. What I will say with that, if they're combative or they seem like they want to harm you or harm themselves, then at that point, you know, don't put yourself in harm's way. Okay? So that again goes back to reading the patient. Special considerations. So always be compassionate and respectful to the patient. That's a given. Does the patient have a mental disability? Are they visually or do they have hearing impairment? Are there any language barriers? Older populations, sometimes their vision isn't great, their hearing isn't great. Do they wear hearing aids and are they in? Sometimes you have to speak loudly. We have an employee here who naturally speaks loudly, and sometimes he gets told.
You probably heard him.
You probably heard him today. That's just his natural tone of voice. Speak softly, try not to be loud and intimidating. If they do have hearing impairment, then speak slowly and, you know, be vocal. If there's a language barrier, sometimes you have to use a different form of communication. We're not that far from the border. If you don't speak French, either if you have an interpreter on scene, or each ambulance should have a language card, and basically that just uses pictograms to ask specific questions. Okay. Google Translate is a great option too, if you have service. Sometimes you can work that. The only thing I will say about that is they can interpret what you're saying wrong, and what the person says back to you might be wrong as well. So use that kind of loosely, I would say.
Yeah, no, I was just going to say, it's like you kind of have to improv a little bit, because like the pictogram card is a good tool. If we can bring it in, it's actually kind of funny because it's got little pictures of like everything. But you know, it's a good thing. You know, kind of side study if you want. Sign language, if any of you know it, awesome.
Great study.
It will definitely come in handy at some point. The other thing, you know, if you speak another language, more power to you, stuff like that. But it's like you kind of have to improv. Like if somebody's got a hearing hearing impairment, like you may have to digress right down to a piece of paper, right? Like, you know,
I've done that before.
what's going on,
Yeah.
and like you hand
I've had
it to them,
communication with
piece of
patients just through
paper,
writing.
something like that. So.
In some
Yeah.
patients, they're lip readers. You know, unfortunately, masks don't allow them to lip read. So sometimes you have to wear a face shield. You know, keep your distance a little bit, and then sometimes they communicate with you through lip reading. You have a few of those. So just keep those in mind. If they do have a mental disability, understand what the mental disability is, how to be respectful towards it. If you need to use another family member on scene or aid on scene, you know, communicate with them as well. Okay. So yeah, make sure I'm not missing anything on that. Pediatric patients. How are we communicating with kids? All right. If you're a parent, you're probably used to it. For those that aren't parents, it's something you adapt to and you learn, especially when we're dealing with really sick kids. Pretty much every kid is afraid of needles, so if an IV needs to be done, that kid's going to be hollering and screaming. Use parents, you know, as long as you're not seeing any signs of abuse or neglect. Parents are a great help to helping us calm the kids. Come down to their level, so when you're talking to a kid, like I said before, kneel down, treat them with respect, and be truthful. Don't ever lie to a kid. Don't ever lie to any patient, for that matter. Okay? Tell the child what you're doing. If you got to start an IV, then tell the child, talk to mom, talk to dad, say, hey, we're going to start an IV. It's going to hurt for a second, but then once it's done, you know, we'll secure it, and there won't be any pain with it after that. Okay, but just be truthful and be honest with them.
I'll just pass this around, but
Yeah.
yeah, this is the little pictogram card and stuff, and I mean, it's got everything right down to like, you know, did you smoke crack?
Are you serious?
Oh yeah, dude.
That one's well used in sales.
It's like miscellaneous, like, you know, you've been drinking heroin, weed, crack, like, did the guy look like this? Did he have a knife? You know, so I'll just pass this along.
Yeah.
It's kind of like,
Great.
I find it amusing because it's got little cartoons and that kind of stuff in it, but yeah. Yeah. So I don't know. I find it funny, but it's like you know, it's got the stuff in there. Like, you know, it could be helpful. Honestly, I've never used it. I've just kind of looked at it and chuckled. But you know, someday it might be there, and it's an extra tool in the box. So some of those little I don't know if you've seen like the EMS field guides. They have similar, like, they have little pictures in there and stuff. Those don't always jive with the protocols, so, you know, if you don't use that as, like, this is my Bible of what to do, but those are handy, too, if you want to keep one in your pocket.
With kids, it can be kind of hard to assess pain in kids, because you're trying to figure out, you know, how much does this hurt? Is this the worst you've ever felt in your life, or is it a boo-boo and you're making it out to be, you know, worse than what it is? So we have this system. It was developed by a physician. His name's Wong Baker, and it's called the Wong Baker Faces. And it's actually a picture of 10 faces.
That's in there.
Is it in there?
Yeah, it's in there.
Okay. So the Wong Baker Faces, and that's what we use with kids to assess pain level. And based on, you know, the look of the faces, are you feeling like this today? Are you feeling like this? It's a great tool to assess a kid's pain level. Okay.
And if you get a chance, Google the alternate one, because it's, you know, like 10 out of 10 is like mauled by a bear or attacked by ninjas.
And some kids have never felt pain before. You know, that's their first incident where they felt pain before, and it's the worst pain they've ever felt in their life because that's the only time they've ever felt it. So, based on what you see. So again, to stay at a child's eye level, the Vermont Teddy Bear Factory, affiliated with Blue Cross and Blue Shield, and they donate teddy bears to every EMS agency. So every pediatric call that we go to, we have a bear in the truck that we give to the kids. That's just kind of one of our calming tools that we use. It makes, you know, them comfortable. Some kids are like, I don't care about this thing, get it away from me. It's an option.
If they were mauled by a bear, don't give them the teddy bear.
They probably don't care so much about there at that point.
Last week you got bit by a dog. Here's a
Here's a puppy. Yeah. Take with what you got. So yeah, sometimes if they have a toy or whatever and you want to do a procedure, show them what you want to do. Use that toy. You know, this is a perfect example. They want to put an oxygen mask on. That kid doesn't look like they need an oxygen mask, but just to show you, he's using that tool as the kid. This is how the mask goes on, and this is what we would like to do. Okay?
Have you seen the baby O's bear? We used to have one of them up in Morrisville, and it's like a little rubber bear for like children like blow by oxygen. But it's like an oxygen tube hooks in the back, and right here is like so you're like, hi little baby, and you just like blast them in the face with it, and they don't even know. Like,
They showed us that on our.
baby O's bear, yeah.
Yep.
We ain't got that.
When we cover medications, we'll talk about that. Different ways to administer oxygen. They do make toys that are able to administer oxygen, which is kind of cool. So be respectful, be open to kids. The other thing you'll notice with this child is they are restrained using a PD mate. Anybody ever heard of a PD mate? So a PD mate is basically a restraint system for kids that straps directly to the stretcher. It uses a series of buckles. It wraps around and adapts to the stretcher, so that way you can secure it appropriately to the kids. Because when we're transporting a child, never ever are we ever transporting somebody unrestrained. You're just asking for a lawsuit. Okay? So if there's no car seat available, or they were involved in an accident and that car seat is now null and void, now we have the PD mate. Okay?
It's also nice because like a traditional car seat for a small child, if the child goes into respiratory arrest and stuff, managing an airway in like a seated car seat position is much more difficult. That will you can just drop the stretcher and they're lying flat, but they're completely secured. So it doesn't interfere with your treatment at all. So those are a worthwhile investment if your agency does not have them.
Yeah, and that's actually a requirement by the state. You have to have some form of restraint for kids of all age groups.
What would you do for like a newborn?
So
That's
newborn
still like
infant.
in the infant type of seat.
Is a great question. So, so let's say you do a delivery out in the field, and you got to transport mom and baby.
I know it would be like mom's chest and
Yep.
she'd be strapped in, but I think
That
that
is
was a little bit
100%
older
okay.
than that.
Yep. So
Like say like 6 months to 6 weeks to like 6 months, where they're not quite in those type of
Yep.
not quite harness yet.
So the other thing we have, depending how sick the child is, you can see it on the back. This is the captain's seat. This captain's seat actually folds down to a pediatric car seat that will fit that age group. So the PD mate, depending on which one you have, if you have the larger one, it won't necessarily fit an infant, especially a smaller infant. So in that case, if the child's too sick, they can't be secured there, then we'll try and adapt the PD mate and using a series of restraints with the stretcher as well.
If the family does have an infant-style car seat, you can secure that to the stretcher too, and that would be, it's like you're gonna run into situations where it's like this is less than ideal, but it's kind of the best we can do, and that's
It happens from time to time.
just happens time to time. You just try to avoid the half butting.
Yeah, and just think ahead on it. Like, if you're transporting and you get into an accident, is the child secured? Are they going to go fly? If you feel that they are, then you're not transporting at that point. You're coming up with something else to secure that child. So just think ahead on that stuff. In the event of an accident, are they going to be okay? All right. If you deliver in the field, it's completely okay. Secure mom to the stretcher, and mom will be holding baby with a restraint across mom and baby as well. Okay. Any questions on that before we get into documentation? Okay. Pre-hospital care report, PCRs. This is kind of my bread and butter. I write very detailed PCRs. The reason I do so is because this is how we explain everything that happened on that call. We're going to get into the legality side of this, but basically this covers you in the event of court. If you ever get subpoenaed into court, this is the first thing you're going to go to. Okay? Because everything that you did and you documented is what's going to be discussed in court. If you left it out or you lied, that's a big no-no. They're going to tear you apart on it. So your PCR. It's a written document of what happened during the call. There's different forms of it. There's the handwritten form, that's kind of the old form that was used. So on our laptops and tablets, we use the siren reporting system for Vermont. That's Vermont specific. Other states nationally, they have their own different documenting system, and that's all computer based. So whenever we complete a call, that's the first thing you're doing. So by Vermont law, you have 24 hours after the call occurred to complete a PCR report.
Your
Okay.
agency's policies and procedures may say otherwise. Like,
Right.
it's 24 is like the maximum allotted time. Like usually, like here at AmCare, it should be completed immediately, but by end of shift is the standard. So.
And sometimes you get banged out one call right after the next and you don't have time to finish your reports in between. So once you get that downtime, take that time to do your reports. And I mean, that's a good golden rule because 2 days from when the call occurred, you're not going to remember everything, right? So trying to get that report done as soon as you can, it's fresh in your mind, that way you can remember everything that happened and everything you did. So right
Especially if
now-
you're really busy,
Yeah.
like calls start to blend together,
Yep.
and then you're like, did that one get aspirin? And it becomes a nightmare. And then you're trying to get times, and like it's bad practice. You'll figure that out if that's what you try to do. Like,
Yeah, and right now we're using computer laptops. Soon we're going to be getting laptops. Monitors nowadays, they will actually automatically upload vital signs, EKGs, all that stuff will be automatically uploaded into your report, which is fantastic. That technology does exist. So iPads, eventually we're getting those, and it just makes documenting so much easier. Handwritten form is still accepted in the state of Vermont. However, if you do a handwritten form, you still have to do a siren report. Every call requires a siren report. Okay. When it comes to National Registry, when you say siren, they're not going to know what you're talking about. So a pre-hospital care report is a report that's completed after the call. So patient care record. Okay. So when we fill out a pre-hospital care report, that report becomes part of the patient's medical record. Okay? So that's kind of the importance of not falsifying information and not omitting information. Okay? Because that information you provide is all part of the patient's medical record. So a patient care record, document findings and treatments, convey picture of the scene, so that's your chance to really explain what happened. And you get really detailed with that. When you're trying to explain the scene of an accident, you got to put that into words. So I get made fun of for it, but when I'm explaining a scene, let's say there's an accident on I-89, I say a gray sedan was in the southbound lane off the west side of the interstate down an embankment approximately 30 feet. The patient was located 100 feet from the vehicle. Okay, really get detailed and paint that picture as to what you saw when you arrived. Sometimes, like Derek said, those calls can blend if you go to multiple accidents right in a row. So that's why it's important to write down your information while you're on that call. So convey a picture of the scene, enter into patient's permanent, so all your information is entered into the patient's permanent medical record. It is a legal document. That's why you cannot falsify information and you cannot omit information. You can be subpoenaed and used as evidence. So if you get subpoenaed into a court case, that's what they're going to pull. That call, typically when you get subpoenaed, didn't happen the previous day. It's typically a year to 10 years out before. So try to remember a call that happened a year ago, right?
especially the way the court system is backed up due to COVID
Yeah,
right
especially
now.
right
Like,
now.
dude, you're not going to see any of these calls for 5 years, like
Yep.
the ones that we did today. Like,
So this is your chance to kind of cover your butt and explain everything that happened. It may help a patient win a case. So if you commit information or omit information, so falsify or leave it out, if the patient's suing you for whatever you did and you didn't put your information into that report, you just gave them the case. Because now the court's going to look at that and say, well, you didn't document any of this and the patient's reporting this stuff. I've got nothing else to go by. So it's basically your word against theirs. It may be used against you in a case of negligence. So what would be an example of negligence?
be able to treat at the same level that somebody else would treat at.
Exactly. It's a perfect textbook answer. So you did not do the things within your scope that could have helped save the patient's life, or the treatments or procedures needed required to help with that patient's care. So this is your opportunity to kind of cover yourself on that stuff. Administrative data, so things that we don't necessarily deal with, but billing information, so insurances and that kind of stuff also gets uploaded into our reports. We have a billing personnel that works for us, and that's what she deals with, is obtaining the billing information, inputting that information into the report, and then using that to send a bill to the patient and the patient's insurance. So getting an appropriate billing address, that kind of stuff. However your agency does that, they have their own policies for it.
I'm just going to track back to the standard of care thing there. So as far as like the negligence thing, like that, I'm going to do the same thing that a provider of my level is going to do. If there's something you don't do that, like say, so in the state protocols at the advanced EMT level, it basically just says establish IV for like everything. If I don't do that, I document why I didn't do that. Yep. Like IV access considered deferred due to lack of peripheral sites or proximity to the hospital, or something like why didn't I do an IV? So I write that in there, not just like so if it ever comes back like why did you start an IV? Like it's in there as to find like why I did.
Exactly.
And as long as it's like if I'm 2 minutes from the hospital, it's like well they're not really gonna knock me on it because there's at the A level there's not a whole lot IV that I'm it's like look at that it's there woo like there's not a whole lot that I'm gonna do to save their life via IV. So
Right.
The hospital use the same port, or do they put their own in?
Depends what they're doing with it.
Depends on the hospital too, because like UVM will draw labs off of our sites, and most hospitals will. Northwestern likes to establish their own IV for their labs. Some hospitals will like you would draw labs in the field when you start an IV. So just kind of it's really area dependent, but yeah, just wanted to mention that.
Yeah, so no, that's a good point, and that can really come against you if you're going to a chest pain call and you decide not to give aspirin. The standard of care for chest pains is aspirin, and if you decide not to give aspirin, explain why you didn't give aspirin. The patient wasn't able to take the pills, or they have an allergy to the medication, that kind of stuff. Just explain yourself why you didn't do it.
Or contraindication, or unable to chew the pills, or like it doesn't really as long as it's a legitimate reason, it's a reason. It's like not just like I didn't feel like giving aspirin.
Yep.
Like, that's not gonna fly. But if you got a reason for it, then they're just document it.
Yep. What about, let's say, you have a question?
What would you do for a patient who is having a heart attack that's allergic to aspirin? Like what would you do to help?
So I would inquire what their type of reaction was. If they say, oh, it gave me an upset stomach, or I got a severe headache after receiving the aspirin, really kind of figure out, did you get anaphylaxis from this and it could kill you, or was it just a side effect you felt?
Right.
I will say that-
Hypersensitivity versus real allergy kind of thing, because we've had people that it's like, oh, I don't like fentanyl because it makes me dizzy. It's like, yeah, that's just that's what it does. It's not really an allergy.
But like if somebody's like actually like severely allergic to it,
I'm not giving it.
Don't give it.
Nope.
There are
is
other
there like other things you could give them in place of it, or?
And
For
our
him,
field,
yeah.
as a paramedic, there are a few things that I can give in place of it. At the EMT level, not really. The best thing with a heart attack or something like that, realistically, what's going to save that patient's life is the cardiac cath lab, right? So time is tissue. So the longer we sit and wait, more tissue's dying. So time is of the essence of that. Aspirin just provides, we'll get into aspirin and chest pain and all that stuff later on, but aspirin just provides, it works as a platelet aggregate to prevent further clot buildup.
Makes the platelet slippery.
Yeah. Prevents the clots from getting bigger, basically. So what about in the case you wanted to give a medication, but you gave the wrong medication? Are you documenting that?
Yes.
Absolutely. And you're telling the hospital that as well. It is the quickest way to lose your license and get into a lawsuit if you don't tell the hospital what you did and you don't document it in your report. Okay? You're going to get in trouble either way, but it's worse if you lie about it or you don't say anything about it. Okay?
It's kind of like what you tell your kids, you know, it's like you're going to be in more trouble if you try to hide it.
Exactly.
And it's, medication errors happen on a daily basis in the United States. It's not necessarily going to be the end of the world, but you know, it's just better to own up to it. Like, hey, you know, screwed up.
There's a process for it.
Kind of going back on the allergy thing, what if you give a patient that didn't realize they had an allergy to something that they're allergic to, you automatically give them epinephrine, or?
So it really depends on how severe of a reaction they develop. So more moderate reactions, like they get hives, the itchiness, that I'm not so concerned about. And we'll get into anaphylaxis later on, really understanding, because we get a lot of calls during the day of, hey, you know, so-and-so's having an allergic reaction, you need to get here now. And the immediate thing that's going through our mind is, oh my God, they're dying. Because anaphylaxis can kill you really quick. And we'll get into kind of the difference between, you know, a mild allergic reaction versus full-blown anaphylaxis. But if they do develop full-blown anaphylaxis, then yeah, we're giving epi and we're treating that. Okay.
Yeah, and in your documentation of that is just you're going to kind of, you know, go back and I guess kind of cover yourself as far as like, you know, verified the patient, you know, stated that they had no known drug allergies. Aspirin, for example, was administered, blah, 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 blah. Patient began to develop XYZ symptoms and treated as, you know, so it's not like, so the thing is going to be like, if you didn't ask about allergies and you're just like, aspirin, and they're like, oh, and then they die, then that's a problem. But if you verify and they're like, no, I don't have any known allergies, you know, yeah, I've had aspirin before, and then they have it, you just document all that. Like,
yeah, you're not going to, I mean, you didn't know, you're not going to catch flack for it or anything like that.
And that's where the documentation is like uber important, because that's what is going to save your bacon at the end, like if something like that happens.
Yeah. Absolutely. So yeah, and any medication errors, always make sure you're upfront with them. Tell the hospital, put it in your reports as well. I hope none of you ever make a medication error. That's a lot of paperwork and that's a lot of QA review and that kind of stuff. But just be upfront with everything. Okay. So we talked about administrative data, insurance information dependent on your service, if they require you to get the insurance information, or if you have a billing personnel who obtains that information later. Education and research. So this is the big reason we have Siren. All of those check boxes we do, those click downs and that kind of stuff, that is all a big part of clinical research. So Vermont Department of Health, orthopedic surgeons, Trauma Surgeons of America, that kind of stuff, when they conduct research, that's what they're pulling. That's what they're looking at. And that's why it's important to do that kind of documentation. They're not necessarily looking at our narrative. Our narrative is our own piece that we talk about to explain the call, explain what we did, that kind of stuff. But when we do those check boxes, a lot of that is used as clinical data. So they'll pull clinical research, they'll pull the statistics, and that's how they adjust our protocols every 2 years, dependent on what the research is showing. And continuing education. So when we QA, QI, we set up trainings. We'll look at our runs and say, hey, Derek's only at 50% on his IV success rate. Well, guess what we're doing today, Derek? We're practicing OVs, right? At the medic level, that's a big thing because we have to maintain a standard with intubation success rate, even field diagnoses, that kind of stuff. They really QA us on that stuff. So that's all important for education. Tracking an EMT's personal experience, so I can see what type of calls you're going on, and you know, you just got your EMT license, I'm seeing you're going on a lot of chest pains, but you've been an EMT for a year and you haven't seen a single trauma. Well, let's work on trauma scenarios, so that way you're prepared.
The other thing about that, if you're going like paramedic route, so NHTI in New Hampshire, the New Hampshire Technical Institute, their paramedic program requires documentation of 75 EMS calls where you were the crew chief during your application process. So all these things is like, crew chief, like we're, depends on your agency who, like, how do we run that, but that's something you can pull to be like, yeah, I did, like I've run 75 calls, like let me into this program. So that's another, personal experience aspect.
Exactly. Quality improvement. So routine call review. Routine calls are the calls that we go on a daily basis that we take for granted. Hopefully you never do that. But just having that quality assurance process is important, and we use our PCRs to really determine that. Ensures compliance to standards. So you went to the same patient 10 times for chest pain and you didn't treat or transport any of those times or treat. But let's look into that and make sure that you're providing that patient with the standard of care that they needed. It can reveal providers deserving special recognition. So a lot of times here we'll recognize providers if they went above and beyond. Derek got one of those awards for going above and beyond the standard of care. They just released that this week actually. ALS Provider of the Year, BLS Provider of the Year, Pediatric Provider of the Year. Those are all recognition awards for the state of Vermont EMS that they give every year. And even just at the local service level, somebody went on a really rough call, they did great, you can review that call and say, hey, you went above and beyond on this call, we're going to recognize you for it. It can reveal opportunities for improvement. So the one thing I will say about quality improvement, it's not always to hammer down on you and figure out everything you did wrong, right? Because then if we had that every day with every call we ran, why would I want to do this field, right? So I always want to know what I could do better, but I always want to know what I did right as well, okay? And that's how we can...
Sorry, So I was just going to say, every month in District 1, I think District 3 does it as well, probably other ones, we do a QI, like case review. So if you can sign on to Zoom currently, and each, like, a particular service is selected, and they usually pull 3 calls, and it's just kind of like, okay, like this happened, anybody was here, like talk about it a little bit, what do you think went good, what do you think went bad, hey, why did you do this, okay, that's cool, like, so it's not a punitive thing, it's just a like, hey, like, you guys had an interesting call, how did you handle it? Did you consider this, that, or the other thing? And as far as the special recognition thing, I just wanted to mention, as is tradition, if you deliver a baby in the field, you will receive recognition and the stork pin, as we call it. It's just a little token of like that you did that. So it's tradition.
Yep.
So.
How often does that actually happen?
Rarely. every so often, if you are the lucky, unfortunate person who has to do that, it's kind of a... Yeah.
It also depends on how far you're out. You guys probably don't do it as often as like Richford, for example.
Right, exactly. Yeah, like what was it last year? Richford did have one. Yeah, I know. Like we have done it here, but it's like, I mean, to do a call from 306 South Main to the hospital, she's got to be like delivering at that point because we're just like driving 80 miles to the hospital, like
Scared to death.
Yeah, like. But I say lucky, unfortunate, like some people are all about it, like that's what they want to do. It's a natural process, you're there to assist, but it's, a lot of things can go wrong, so. Yeah.
It's one of those memorable calls that you'll deal with, especially, so I've had one delivery in my career, very premature child. I was terrified, I didn't act it, but I was petrified as soon as I did it. Luckily everything turned out healthy and perfect. The child was discharged from the hospital 2 months after we delivered, perfectly healthy. So yeah, you get a stork pin. Mine was pink because it was a girl. So it's kind of a cool recognition that you can get in this field. So yeah, and I do recommend what Derek mentioned. Attend those district meetings because those are great opportunities to learn. You're actually getting a physician's perspective on the call. And you can find out kind of patient outcomes and that type of stuff. So this is what they did on the call. What happened to the patient? What was their outcome? Did they die? Did they turn out for the better? That kind of stuff. It's a good opportunity to figure out.
Because as you'll find that this field in particular, like closure is not something you get all the time. You'll have these calls, you'll drop them off to hospital, you may be able to pick their brain later, like, hey, what happened to that person? What was going on? But like, 9 times out of 10, that's the last you ever see of them. You have no idea. So it is nice, some of those, because they don't pick the routine, like little old lady fall down, go boom calls. They pick the more high profile ones that are like, that you're actually like, I wonder what happened, you know, like, you know, what was wrong with that guy. So that is kind of nice to get that.
Yeah. And with Siren, there is actually a little tab you can click that you can put in a request for review, and then you can find out feedback later on. You can review it at the district meeting or with a physician to figure out what you did. So yeah, that's quality improvement. Data elements. So developed by the National Highway Traffic Safety Administration. So that's our big governing body that oversees EMS. That's what we're a part of. That will be on National Registry. I can promise you that. So when they ask the question, who is the governing body of EMS? That's our governing body. Okay? So developed by the National Highway Traffic Safety Administration. There's more than 400 elements that they overview. Minimum data set available nationwide. So those are things you can look up on their website and stuff. And that's basically where, you know, nationally they'll look at calls, they'll look at trends. They can see, hey, there's an upscale of opioid overdoses this year. And that's where community projects come out, you know. Narcan's being placed out in the public, community awareness, stroke. That was a big thing, heart-safe communities, that type of stuff. So they take all that data and they look at that and say, you know, what are we seeing trends right now? That kind of stuff. So we're totally involved with that. Run data. So agency name. So this is all the stuff that you incorporate in your PCR. So obviously the agency you're working with, the date and times, call number. We have our own specific call number. Each agency has a little different call number depending how they do it. Unit, personnel, and levels of certification. You have to have that on there. On Siren, there's tabs for that. And other basic information mandated by your service. So whatever other information they require about that call. Use official time given by dispatch, so all times and report match. Can't stress that enough. If you get subpoenaed to court, they are going to look at that. Okay? So make sure your times match up with central dispatch's times. Patient information. So we're putting in the patient's name, address, phone number. Phone number's not really that important. You don't have to have that in there. I don't ever ask the patient for their phone number to incorporate. If it is a special population or if it's a pediatric, then I will put in the patient's guardianship information. So that way, I like to have that information. If we ever got called to that child at school, who am I contacting? You know, who am I getting permission to treat the patient? That kind of stuff. That's where that really comes important. Patient sex, age, date of birth. You have to have all that information. Weight. So weight in kilograms is preferred. Race and ethnicity, that's not as important. There is tabs for that if you want to incorporate that in. That's personal preference. It's not something that's required to be put in. Billing and insurance information, again, that's service dependent, whether you have to get that information or if you have billing personnel that get that information. So that's patient information. And again, remember HIPAA, okay? Anything you write down or document, if that goes out into the general public, that is a HIPAA violation and you can be sued for that. So make sure everything you're doing is compliant with HIPAA. Information gathered during the call. So general impression of the patient, you arrived on scene and what did you see? I saw a 40-year-old male sitting on the couch in a tripod position, breathing heavily. Okay, that's really important to really kind of establish the setup of the scene as to what you saw. It's really explaining, you know, if you go to a car accident, what did you see at the car accident? How were the cars positioned? Where was the patient in relevance to the car? That kind of stuff. Your narrative is your summary of your call, so that's your own typing out written documentation of the call. Some are short, depending on what happened, no patient contact, that kind of stuff. They'll be short. Some of them, if you have a priority 1 trauma, that type of stuff, you're going to have a 10-page essay. Really depends on what happened during that call.
We do have a like a narrative format that's. Are you going to talk about that?
Yeah.
Okay.
It does get into it a little bit.
I won't get ahead.
Yep. So yeah, we'll get into how you set up your narrative. You will be tested on that in the post-test and in our EMT, but we do have a format used to document our narrative. Patient's prior aid, past medical history, physical exam findings, vital signs, ECG. So with EKGs, we're not interpreting. Unless you're at the medic level, you can't interpret EKGs. You're writing whatever doc in the box says. So if it's saying normal sinus rhythm, that's what you're writing, normal sinus rhythm. Procedures and treatments, medications administered, other information required by your service. Okay. And then transport information. Was the patient a sign-off? Did you transport them? And what facility did you transport them to? Pretty general. So the narrative, this is what Derek was talking about. So we have objective and subjective information. Somebody give me an example of what objective information would be.
It was warm out today.
It was warm out today.
Patient was female, blood pressure, etc.
That is physically what we can see, touch, whatever, feel, something that's measurable. All right? So if a patient's complaining of chest pain, is that subjective or objective? Subjective, right? Patient's blood pressure is 102/83. Objective. Really know the difference between those two because that's how you're going to document your information. If I see a laceration above the right eye, it's objective information. It's what I'm seeing. Okay? So remember those. Objective is observable, measurable, verifiable. Subjective is information that's either opinionated or interpreted by the patient. Okay? Any questions about those two? So in your narrative, I use the D-chart system. Anybody ever heard of the D-chart system? So D is dispatch. That's my first point. What was I dispatched to? I was dispatched to etc. address for a 25-year-old female, chief complaint abdominal pain. MK 36 responded to the call immediately with lights and sirens in due regard, and we arrived on scene without incident or delay. Okay, so that's all of our dispatch information. So D, C for chart is chief complaint. So what is the patient's chief complaint? Abdominal pain, chest pain. Sometimes the patient has multiple chief complaints. I'm feeling dizzy and lightheaded and my left arm hurts and I can't walk very well. You do try to kind of narrow down what the main complaint is. A lot of times there isn't a main complaint, so you're going to incorporate all those. So your chief complaint is the primary complaint stated by the patient. If the patient's unresponsive, what's our chief complaint? Unresponsive, right? It's best recorded as a direct quote, so don't put your own interpretation of what the patient's chief complaint is. Go with what the patient's telling you their chief complaint is. We're also incorporating our pertinent negatives, so important negative findings. What would be an example of a negative finding?
I palpated their arm and they reported no pain.
Perfect. So the patient denies any present chest pain, shortness of breath, abdominal pain, nausea, vomiting, headache, or dizziness. Those are all things that they're not experiencing. Why would I want to incorporate that in there?
So you did it? Just proof that you did it?
Prove that we assessed it. We checked for it, right? Because if I don't incorporate that in there, and then later on they find out that the patient was experiencing those symptoms and you never asked about it, that can come against you. So use your pertinent negatives, all right? Explain things that you assessed and the patient denied. Any questions with pertinent negatives? In your narrative, avoid radio codes. We don't use radio codes ever in our field. Non-standard abbreviations, so District 1 has a set of standard abbreviations. I'll see if I can get that for you guys. And that's basically examples of aspirin, we use ASA. Personally, I don't use abbreviations in my report because I want it to be clear what I'm trying to say. Where I do use some abbreviations like congestive heart failure, I'm putting CHF. That kind of stuff. So if you're doing a handwritten form, write legibly. Most of our reports are done through the computer and use correct spelling. Always make sure you're spelling appropriately, especially if you get subpoenaed or anything like that. They can paint a picture of you right there saying, you know, this person's using inappropriate words or they don't know correct grammar, that kind of stuff. It's not huge against you, but it's their developing a view on you. So information must be read easily and accurately, and a PCR is a reflection of your care. Use appropriate medical terminology. If it's not written down, you didn't do it. Okay, it's pretty straightforward. Everything you did on that call needs to be documented. If you didn't write it down, they can't prove that you did it. Okay. So we'll get into special documentation. Any other questions about a narrative? Sorry, I didn't finish D chart. Your D chart. So D is dispatch, C is chief complaint, H is history of present illness. So history of present illness, would that be subjective or objective information?
Objective. It's a history.
If there's a record of it, it's an objective.
So in my history, am I incorporating present symptoms and that kind of stuff? Yes. So it's a little bit of both, right? So in my history portion, I'm incorporating their medical history, which would be considered objective information. You know, if I get a piece of paper, they're telling me I have a history of CHF, that can be considered objective information. But I'm also getting subjective information in there because I'm going with what the patient's telling me. So that the H is history of present illness. Now when I get into A for assessment, is assessment objective or subjective? Objective. Objective. That is where all your objective information goes. Okay? So history of present illness is more subjective information. Assessment is all of your objective information. Okay? R is for treatment. So treatment being treatments you rendered. So what I typically put is monitored mental status, airway, work of breathing, vital signs, cardiac rhythm, and started a 20-gauge IV in the left AC, noted to be patent with no signs of inflammation or swelling, administered aspirin, that kind of stuff. So that's where you're putting in all your medications and procedures you did. And then T is for transport. This is kind of one of the things that falls back, and this is where people get into trouble. How did you transport the patient? How did the patient get from the ground to your stretcher? Did you assist them? Stand and pivot? Did you pick them up and carry them? Did they walk on their own? You need to incorporate that information.
I just wanted to mention, and for anybody who ends up working for, like, say, Garnett or some agency that does, or us, that does interfacility transport, that's also very important when you're because you have to justify a need for ambulances. Like, if you're taking a patient out of the hospital to the nursing home, there has to be a reason why this patient couldn't get in their own car and drive over there, or go by wheelchair van, or have the family take them. Like, you know, and it could be cut and dry. It's like, yeah, patient's a quadriplegic. Like, you know, there's no way you can get her into a car. But some of them get a little wishy-washy. So you have to be, it's like patient is non-weight bearing on the right leg, requires, orthopedic precautions and route stuff. So that's where, how you got them from point A to point B, and how you're justifying, patient did a freaking cartwheel onto my stretcher. Medicare or the insurance is going to be like, then why don't the patient just cartwheel their ass down to the nursing home?
Exactly.
So just the bean counters in your agency that will get on your case if you're not thoroughly documenting that.
Right. So it seems like crazy, kind of dumb information. It is relevant. How did you get the patient from point A to the stretcher? How did you secure the patient to the stretcher? Were they side rails up ×2, straps ×4, covered with a warm blanket, semi-Fowler's position, hopefully not prone. I can't think of any situation that would be prone. That kind of stuff. How did you position them? And then how did you transport to the hospital? Did you transport with lights and sirens? Did you transport with flow of traffic in due regard? Okay? Especially if you get into an accident. That is one of the things they're going to look at is how was that patient secured? If you decided not to put the side rails up or put any restraints on the patient, you're asking for a lawsuit. Okay, so document that in there, so that way it can prove that, you know, they put straps on ×3 and that kind of stuff. And then also in transport, we're also putting report provided to ex-nurse by paramedic Wolski. And then patient signed EMS report completing patient care, that kind of stuff. The other form, so that's D-chart. The other form is SOAP. I don't use SOAP. Do you use
I
SOAP?
don't use soap. No, I use the chart.
So SOAP is subjective, objective, assessment, and procedures. I think I have that right.
I think that's right.
It's not one that I use.
Yeah.
So subjective, all your subjective information, so what the patient told you.
I know nursing uses soap.
Yeah, they use soap. So that just differentiates your subjective and objective information a little more. Not the one that I use, but you can use your personal preference.
Just a quick caveat on what he said, as far as like Garnett, we just do transfers from hospital, nursing homes, whatever.
Yep.
99% of that is scheduled.
Mm-hmm.
And it's all taken down and taken through the system, through the dispatching central desk.
Yep.
But everything you guys have said, as soon as we hit the key on that unit, the time we bring it back, all has to be documented.
Absolutely.
Everything has to be, even though the reason why they're being transported is, we're just getting them.
Yeah.
You know, but that's already been established, and insurance companies are already.
Yeah, so if you already have like a pre-authorization and all that
Right.
stuff, that makes
Right.
it super easy.
Right.
Sometimes you get those cases where the ER is trying to empty out to make available beds, and they're like, hey, I need this patient to go back home, or I need them to go to a nursing home and
And I've
stuff.
heard that has happened with us a couple of times at UVM, where they've actually said, hey, there's Garnett, now you have to start going through the system, and
Yeah.
calling people and say, okay,
Yeah,
we want this person to be taken to Dartmouth,
right,
or whatever, or CVPH.
yeah. And I mean, we don't like to get into that insurance game, so as providers, we try to stay ourselves away from that. It's like, I don't care what insurance you have, or even if you have insurance, I'm here to take care of you. But I will say with that is, ambulances are expensive.
Yeah.
And, you know, if you take a patient unnecessarily to home or whatever when they had other means of transport, and now you're throwing a $2,000 bill at them, you gotta be fair to them as well, right?
The
Be upfront.
911 calls are a given thing, but when you
Right.
start doing the transportation and everything, that gets a whole world
Yep.
of nuts involved.
Exactly.
Yeah, and like agencies that do that for a living, like, you know, like Garnett, for example, you know,
Or
you like,
Rite Care.
or, yeah, so, but, you know, like, it sounds like you guys have like a, you know, pretty good system where you got somebody who's like a specialist on that stuff. They get all the paperwork and then it hits the truck and,
Yeah,
and
between the
then,
dispatches, it hits Chelsea or it hits Jeff, that's it.
yeah,
You know?
so it's like they're squaring away all the paperwork, stuff like that ahead of time. Like, I mean, I can, currently, we're a little late. We have our hands in that aspect a little more than we should. Some of us have, you know, like the supervisors here are generally tasked with determining medical necessity and availability of units for transfers and stuff.
Yeah.
I know with our transition that's going to change, but yeah, a lot of the agencies, I know Lamoille is another example where it's like setting up a transfer, it goes to the billing or the dispatch, you know, they figure all that out, and by the time it gets to us, like, you know,
Okay.
or the Lamoille inns, they
Your
just
Uber-
do the transport.
Yeah, your Uber.
So,
Yep.
yeah.
At that point, you're Uber.
Yep.
So.
Exactly. And I mean, if we do get in those situations where they don't meet the requirement by insurance to require an ambulance, and that's where you get involved with an advanced beneficiaries notice, an ABN, and it's just being upfront with the patient saying, hey, in the event your insurance doesn't cover this, this is going to be the cost of the transport, and are you okay with us transporting you and receiving this bill if your
And
insurance doesn't
then
cover
the
it?
other factor is, it's just like if we got calls out or something like that, and we have like one paramedic that we have on duty and the other one is not available, we can't take a call that requires a paramedic level.
Right.
You know,
Right, we run into the same thing
Same
here,
thing,
yeah,
you
so
know,
it's
we
like,
have to
it gets,
call.
it becomes a logistical
It's a
nightmare, and, you know, it's not really something that, you know, if you're interested in career EMS and that's something you want to get into, more power to you, but as far as like, you know, being the truckies or whatever, that's stuff that I would rather never have got
On my end,
into.
it's like maintaining all the vehicle units that, you know, the ambulance units, the other, you know, supplementary units and stuff like that. And I've got, you know, $1.25 million worth of like equipment, that's 3 units. And 2 times out of the week, usually that's not enough.
Right. Oh, absolutely. It's a huge demand in here.
It is funny too, is like
Then
the,
you have to,
like,
then you have to sit there and supplement your training unit.
Yeah,
You always have to make a training unit.
but it's like, so, you know, like a lot of times the cost of an ambulance is not like, people just don't know. They figure it's like, you know, oh, it's probably maybe $50 or whatever, and then you tell them it's like it's gonna be closer to 2,000. It blows their mind. So ambulances are very expensive.
What's a set of like a set of 4 dualies for back 2 dual wheels
Yeah,
and everything?
so
That's
just-
$4,200 for fucking 4.
Costs a lot of money to run an
Cost of
ambulance.
maintenance is
And healthcare
very
in this country is just
Healthcare is
it's very expensive. So it's but
Nature
yeah,
of
I mean,
business.
we digress.
All right. Any questions with documentation on that? Pretty straightforward. We will do practice documentation later on. Yeah, that's just a general kind
Do you
of
have examples that are redacted?
like examples I can pull from run reports.
Yeah.
I haven't had the chance to pull them yet. I will
Okay.
and show you guys that. I have a few calls.
Do you want me to pull up my little template that I use? Because here, let me see.
So you guys
I gotta write a report. I mean, I can sit down and write out my narrative real quick if they really want to see what a narrative entails.
You really want to get bored to death. So yeah. While Derek's pulling that up, we'll keep going. So narrative sections, I think we already covered this. Recorded as direct quote. Avoid radio codes. It's not written down, you didn't do it. So special documentation issues. Confidentiality. So HIPAA. Accountability and security. So you need to make sure that the information that you're providing, number one, is accurate and it's not accessible to the general public. So basically when you put it into a siren report, siren is a secured system that is only accessible, that specific call is only accessible by the people involved, billing personnel, and then whichever provider at the hospital is taking care of that patient. When we do QA/QI, there is actually a subset section of siren where you can put QA/QI and it removes all of specific patient information.
Do you want to wait on this, or do you want to just look real
Yeah,
quick?
let me crank through this real quick.
Yeah.
Actually, if you want to pull it up on my laptop, you can.
Apple.
Yeah, you need my finger.
You got Touch ID on your laptop?
Yeah.
You even have facial recognition now.
But Apple's are
That just adds $800 to the cost of your
Yeah, pretty
computer.
much. Probably. Example. All right, so accountability and security. So another thing I'll say with this, if you get a patient face sheet, that face sheet needs to stay secured. You can't just take their face sheet, walk into, I don't know, Jolly's, and then you leave it somewhere in there. You just violated HIPAA. So make sure all patient information you have is secured. It's not accessible by somebody to get. Patient refusals, high liability. Why would those be high liability?
Because if you don't transport it, don't give care, then they deteriorate or die on you.
Right. So, this is a situation where we document the hell out of the call, okay? Because we need to explain why the patient refused transport, what we did and what we found, and how we tried to give them the opportunity to go to the hospital, okay? Document all details in refusal of care form. So Vermont has a handwritten form. It's also in Siren as well, depending on what your service uses. Either case, you have to use Siren, but you can also use that handwritten form along with Siren. So those carry high liability, so make sure you document them really well. Falsification, so covering up errors. We never lie on our reports. Recording something you forgot to do. So if you omit something, you forgot to put it in. If you didn't write it down, then you didn't do it. Okay? So never falsify any information that you're given on a patient care report because that's part of their permanent medical record. So what do we do if we accidentally provide information that was inaccurate?
You make the correction in the form.
So are you going directly to that report, deleting out that section,
No.
and putting in new information?
No, you-
Like any
you
legal
put what you
document.
did and what you corrected.
So, in any legal document that you make a correction on, you have to have a history of making that correction. So you need to
Yep.
cross it out, initial it, and then have somebody witness you make that correction in most cases.
So what we do for our reporting system is we add addendums. So in an addendum, you're on that report, you go down to an addendum, and then you put the information, whatever you messed up, and then you also date, time, and initial what you added. Okay? So never just go in and delete anything out. Okay? If you're still working on the same call that you just started and you mistyped something or whatever, that's one thing. But if you've submitted the call and it's gone off to billing and all that stuff, then you need to go back in and fix it. You're adding an addendum to it. Okay? So let's go over an example. Respond to a call for an unconscious male. Upon arrival, the patient is awake, alert, and walking away. He states he was just sleeping and does not need or want treatment or transport. Are we documenting this call?
Yeah.
Good. The patient didn't want to give us any information. He wouldn't tell us his name, date of birth. What are we putting for information? You can put what you see. I'm not going to guess the patient's age, but I'm going to say I saw a younger male who was on scene, refused patient care. The patient appeared awake, no obvious signs of distress, refused EMS evaluation or treatment. You're cleared from the scene and placed back in service. Document it. You have to report that it happened. Central Dispatch is going to have it in their records that you went to that call. You need to have your form of record on it as well. Okay? If that patient refuses to sign your refusal of care, do you have to force them to sign it?
Nope.
Nope.
Individual refuses to sign, date and time.
Exactly. Patient refused to sign the report. It's helpful if you have a witness. So if you have a witness on scene, say, would you be willing to sign my report that the patient refused to receive evaluation and care? That's completely fine if they're willing. Your partner is another example as well. So always document. So, is this a patient? Yes. Is a complete assessment and physical exam needed? If they were willing to receive it. That's kind of situation dependent. If they were displaying thoughts of suicidal ideation, homicidal ideation, altered mental status, or intoxication, that kind of stuff, then you get into a realm of
Elevated mental status.
right. Does this patient have capacity to make their own decisions? That kind of stuff. If they don't appear altered, they're acting appropriately, it was a third-party call, they saw somebody walking down the street and they wanted them assessed, it's well within that patient's rights, as long as they're maintaining mental capacity to refuse us. So how will you document this call? We're just documenting what we saw, what we did. And should you obtain a formal patient refusal? If you can, great. If you can't, then you just document that you couldn't get a refusal. So multiple casualty incidents, MCIs. This is where documentation becomes a nightmare. So it's a logistical problem for EMS because we're dealing with multiple patients. We're trying to get the treatment that those patients need, and at the same time we need to document what we did so the report can be passed off to the hospital. So documentation of information for individual patients is difficult. Care and evaluation by several providers at different times and locations. So when you start getting into different stations, this provider's focused on assessments. That provider needs to provide that information to the treatment station, right? So they know what to do. So in our MCI bags, we actually have tags that goes with each patient. It's just a quick verbatim breakdown of quickly, were they awake? Did they have a pulse? Were they breathing? And what else did you find? And then that can be provided off to the patient or to the next station. Important to keep information with patients from an MCI scene as they move through the system. So making sure that continues on with the patient. That's why we have those special salt triage bags. Special situation reports, exposure to an infectious disease, injury to yourself or your partner, hazardous or unsafe scenes, referral to social service agencies, and mandatory reporting. So, this is where documentation increases for us. So exposure to an infectious disease. I started an IV and I got stuck by that same IV. Do we document that?
Mhm.
Absolutely. Right? On the side of that, we also have to do our own portion. in dealing with the infectious disease or infectious control officer, making sure we take care of ourselves, getting evaluated, that kind of stuff. Injury to yourself or your partner, that's something we'll document as well. Hazardous or unsafe scenes. So if we were delayed getting on scene, why were we delayed? Well, the patient was combative.
Traffic accident with a chemical spill.
Chemical spill, exactly. Document that delay. Document what they were exposed to. Referral to social service agencies. So this is a case where you're trying to get, the patient is requesting additional help, like you want to get them a life alert bracelet or something. Having those resources available to refer them to. If you feel they need home health services and you want to talk to their primary care physician, those are all options you can do. And then mandatory reporting. So APS reports, that kind of stuff. With EMT licenses, you are a mandatory reporter and you need to report what you saw. You can absolutely get in trouble if you neglect to provide that information or act upon it. Okay. You have a question?
Just real quick, at what point do they become, okay, so, well, at what point are they an individual and a patient? So if we go and we're gonna treat them, but they don't want it, are they still the individual and we'll put that in the report? Or if we treat them and they accept treatment, or they accept treatment, do they become the patient and their name goes on the report?
So I play it as, that's the person I'm called to, they're a patient.
Okay.
You can also list them, so certain situations, sometimes I list occupants. So if you have multiple patients in a vehicle and your report is dedicated to patient number 1, then I will document patient number 1 was located in the driver's seat of the vehicle. 3 other occupants were in the vehicle as well. This report is specific to patient number 1.
Okay.
That's an
Commander
example.
reports on child and elder abuse, if you're going to actually make a report on that, just make sure you call the authorities that need to respond. Because you suspect of it, you got to report it.
Right.
Yeah, that's
so-
a good point too. Like, there's a procedure
Yeah.
for
You're gonna-
notifying
you're gonna
DCF or
write it down, you gotta
APS.
call
Like,
the agencies.
Oh, yeah, absolutely.
Protective services or whoever.
yeah, there's you like just telling the nurse like, hey, I think this child's being neglected doesn't count. Just telling me, like, if I was your supervisor, doesn't count. Like, there's a procedure. Joe, you were gonna say something regarding that, or can you speak up now?
No, I mean, I've done APS reports before, and you can either do it online or by phone.
Yeah.
So,
Well,
APS,
there's situations, so it's like, in my former, line of work, we go into a situation, obviously there's children involved, they may not be directly abused, but you got a crack house or something like that, Child Protective Services is gonna come.
Yeah, I had a stretch where I had DCF on speed dial,
It's not
basically.
going
Like,
to
I don't
be-
know, like, what was it?
It's not gonna
Hey,
be
it's
like,
Derek. Oh, hey, how's it going? Yeah, I got another one for you. So, yeah, like,
it's like, because that basically involves, you're actually taking responsibility for that child and elderly person, so you can, and that would be considered abandonment.
yeah.
It would be.
APS is a little quirky because APS usually does follow up within 48 hours, and they really stretch that 48 hours. DCF is very much on top of it. They are well within 24 hours.
Minor
as soon as
children
you
have
call
to be,
it.
it has to be immediate.
Yeah.
It has to be immediate.
you'll generally get at least in my experience, you get a notification like eventually from DCF as far as like, hey, like we investigated, nothing to see here, or kind of like you do get a little closure on those usually, or at least I did in the past. So
yeah, filing APS and DCF reports on top of your siren report. That's a lot of paperwork.
the DCF report is there's a hotline that counts as like usually they'll give you like an intake number and stuff, so it's relatively painless. It's just as far as documenting it within your PCR is going to be.
And if it actually is a case involved, you end up getting a case number because you are involved directly as a witness.
Exactly. Any other questions with that? Special considerations? That's it. We'll let you go through the chapter review.
Yeah,
I show them.
I just want to show you. I don't know how to make this. Do that. So
Am I gonna screw this up, Joe?
yeah, you're gonna, as soon as you unplug the HDMI, it's gonna stop the recording.